at Bharat Hospital Institute of Oncology, Mysore, for the welcome and introductory note and to take the ball rolling, to set the ball rolling. Over to you, sir, for your kind introduction.
Thanks, Ektaji. Hi, good evening, friends, teachers, colleagues. Today, I welcome you for the day 2 symposium on recent advances in medical oncology. At the outset, I would like to thank all my academic partners, AstraZeneca, Roche, Natco, Zydus, Novartis, Johnson & Johnson, Takeda, Bayer, Intas, Merck, and Glenmark Oncology for their generous contribution to conduct this meeting. And today, we are going to have a day 2 symposium, which consists of genitourinary session, gynec oncology session, colorectal session, biliary tract oncology session, and finally, we have a supportive care oncology session as well. We have wonderful case-based discussions today from our eminent speakers. With that, further much ado, I would like to welcome Dr. Ashna Narayan, who is a genetic counselor from Core Diagnostics, Delhi. I welcome you, ma'am. She's going to talk on HRR and HRD testing in oncology. Over to you, Dr. Ashna.
Thank you so much, Dr. Srinivas, for your warm welcome. So I have been given the opportunity to talk about HRR and HRD testing in context of genitourinary and gynec oncology. So let me share the screen. We'll start the I hope my screen is presenting, right?
Yes, ma'am, it's visible. You can start.
So we'll start with, burden of cancer cases is significantly rising in India year by year. And in context of genitourinary and gynec cancer and HRR and HRD testing, we will be shifting our focus to prostate cancer in males and ovarian cancer in females. And prostate cancer is the second most frequent diagnosed cancer in men in India. And for ovarian cancers, India accounts for 76.5% of incidences and 75.5% of mortality. So it is quite high. And these cancers are usually detected in advanced stages, and therapeutic interventions at the correct timing is very important. In the age of NGS, tumor profiling test has become a routine practice, but majority of them do not know which test to perform first, whether it is somatic, whether it is germline. So firstly, this is one of the Globocon data where you can see ovarian cancer ranks 8th in India and prostate cancer ranks 12th. When we talk about genetic testing, there are two types of testing, germline testing and somatic testing. Firstly, when we are looking for hereditary cancer predisposition genes, then only we offer germline testing, and it is done on blood. And somatic testing is tumor profiling testing. So it is done for therapeutic, targeted therapy purposes. And the main difference between both the tests is germline testing, basically the mutations detected in germline can be passed on to next generation, but the mutations detected in somatic cannot be passed on to next generation. But yes, we do take account of the variant allele frequency. If it is more than 50% in the patient, then further recommendation, further Sanger confirmation is suggested in the blood. This is some of the this is BRCA testing, which is very well known in India and other countries also. And in context of HBOC syndrome, hereditary breast and ovarian cancer syndrome, which predisposes anyone to breast cancer, ovarian cancer, prostate cancer, and pancreatic cancer, ideally the first thing which strikes any doctor is if any patient who has been diagnosed with prostate cancer and ovarian cancer is to conduct BRCA testing. Now, this is the NCCN guideline. As per the NCCN guideline, this chart is there. With the personal criteria, family history criteria, or pathology of the cancer, you can recommend any patient to undergo the BRCA testing. And there will be therapeutic implications. That means for the eligibility of PARP inhibitors. So where does HRR testing comes? HRR, homologous recombination repair. So when we when we go to the when we talk about the carcinogenesis, it is a complex process, and in our body, genomic stability is something which has to be maintained so that carcinogenesis, the process of carcinogenesis, do not occur. So HRR, it is a DNA repair method, basically it's a double strand break repair method. It is one of the high fidelity pathway for DNA break repair. Now, when we were talking about BRCA testing, when we come to HRR pathway, there'll be BRCA1 and 2, because these are the two widely studied cancer genes. But there are other genes also which are included in this pathway, including mRNA complex genes and strand invasion genes. So HRR pathway genes would include not only BRCA1 and 2, but other 12 or maybe small low penetrant genes also. Now, mutation in any one of the genes may result in the phenotype of homologous recombination deficiency. About this term, we'll be discussing in few slides. So this pathway can be inactivated by numerous somatic events, mutations, deletions, methylations, and it, or with or without association of germline mutation in many solid breast cancer, solid tumors, basically breast cancer, pancreatic cancer, prostate cancer. So why HRR test is recommended for the patients who have been diagnosed with genitourinary or gynec cancer? There's a concept called synthetic lethality, in which PARP inhibitors are targeted. So basically, this is the structure in which this is the diagram in which you can see PARP inhibitors target the PARP enzymes, and it inhibits the PARPylation process, and it traps the inactivated PARP on DNA, resulting in the generation of double strand breaks. So because preferential targeting of tumor cells, so it spares the healthy cells, and it provides the patient with benefits that are not achievable through the conventional chemotherapy methods. So basically, HRR panels enables the clinicians to identify whether the patient is eligible for PARP inhibitor therapy and increase the patient's chance to fight cancer with FDA approved inhibitor therapies. So this is the, you can see if a PARP inhibitor is introduced in the body in any advanced cancer cases, especially prostate and ovarian, it basically makes the DNA, the tumor cells in which HRR, whether it is HRR proficient, whether it is HRR deficient, it leads to cell death. Now, for prostate cancer, the frequency of HRR mutation varies from 11.87% in germline mutation and 23% for somatic mutations to 33% for germline and somatic mutations together in NCRPC cases. So this is one of the NCCN guidelines where HRR testing is recommended. Firstly, in somatic, that means in tumor. Then if it is not done or if it was inconclusive, then it can be done in the blood sample as well. This is you can see the targeted therapy. PARP inhibitors can be used as a second line therapy or as a maintenance therapy. So for example, if someone in some of the cases in platinum sensitive therapy are introduced and they're responding well, then doctor may suspect that, okay, if it is there, then it could be BRCA mutated case. So then HRR testing can be conducted, BRCA testing can be conducted. And if a BRCA is mutated, then PARP inhibitors therapy can be also introduced in the treatment of the patient. This is FDA approved indication for ovarian cancer, where PARP inhibitors, niraparib, oraparib, rucaparib, it is used for as either maintenance after recurrence or as a second line therapy. Now, when we talk about HRR testing, as I mentioned earlier also, there are two types of testing, HRR somatic kind of testing and germline. So there are two types of HRR testing also. HRR testing can be either done in block or in the blood. When we talk about HRR somatic testing, which is done on the block and the tissues, there are certain benefits and limitations. The main benefit is that it can detect both somatic and germline mutations, but it cannot differentiate between the two. That means if any mutation is detected, yes, it is there, it is present. If it identifies a great number of patients who may benefit from PARPI therapy and requires less extensive genetic counseling at the outset because it is therapeutically indicated. Now, reverted BRCA1 mutation can identify patients resistant to treatment. But there are certain limitations also, starting with type of mutations are not well defined because it is this kind of testing. Somatic testing is not well studied. Now, preliminary data are available on the response to PARPI, and the sample, if you're sending sample for somatic test, then tumor content should be enough. The tumor quality should be enough. And if there is any kind of quality issues with the tumor, then result cannot be produced. Analysis will not be possible for technical reasons. And requires additional expertise and in pathology also to determine sample adequacy. When we talk about HRR germline testing, which is conducted in blood, there are multiple benefits and there are limitations also. Benefits include validated method because it is a widely studied method. Patient protocols, pathways, procedures are well established, unlike in somatic testing. Evidence is strong. If a mutation is reported in germline, that means there will be a strong evidences related to that mutation. And sample collection and quality of DNA can be higher than the somatic, in normal cancer, tumor cells. So sample collection is easy because it can be conducted in EDTA blood. Now, analysis is feasible in 100% of cases, but there are limitations also because blood testing, germline testing would not detect somatic mutations. It depends on the pipeline. So if you are only suggesting HRR germline testing, so you may miss out somatic mutations. And genetic profile of the tumor may change with disease progression and chemotherapy. This is the overall view where you can see where HRR somatic and HRR germline testing can be administered. For example, if some doctor is sending for BRCA somatic and it came out to be negative, then they can think for HRR somatic in the case of prostate, metastatic prostate and ovarian cancer. If that becomes inconclusive and you're not obtaining any kind of result, then HRR germline can be done. And if everything is negative, conventional therapy can be used as indicated. But if either of the tests becomes positive, there is aid in therapeutic decision. That means eligibility of PARPI. So when we talk about HRR, it only defines the eligibility. It doesn't mean that PARPI will definitely or effectively act or impact the clinical progression of the patient. And also, if any of the somatic tests becomes positive, we need to consider the variant allele frequency. If it is more than 50%, then it has to be considered for blood testing or germline testing also. When we talk about germline testing, we need to talk about hereditary cancers also. So if any kind of germline testing becomes positive and relevant to the patient's cancer, and it is pathogenic in nature, then you have to recommend for risk analysis in family. One thing to be noticed here that all of the HRR germline genes may not have certain definite guidelines. So you need to check with the family members about the family history, then only any kind of recommendation has to be made. Now we'll be coming to HRD, homologous recombination deficiency. So in industry, we usually confuse about HRR and HRD testing, that why HRD testing is done, why HRR testing is done. So this homologous recombination deficiency, it is a tumor characteristic. So HRD is one of the consequences, losing HRR capability. So yes, in the HRR genes path, HRR pathway genes will be there and it will be tested. But in HRD testing, HRD scar score is generated by 3 genomic instability markers. First is the testing of BRCA and BRCA-like genes, which are involved in HRR pathway, in which we check loss of heterozygosity. There is another biomarker, which is telomeric imbalances, and third is large-scale transitions. So combining the 3 genomic instability markers by combining an analysis of this, a scar score is provided in HRD reports. And HRD score of This is one of the studies which was published in BJC, showed that if a HRD score is more than 42, then the patient will have a significant impact through PARP inhibitors therapy. So you can directly go for PARP inhibitors treatment, and it will be effective, and good prognosis can be made. It is done by various studies. But one thing to be noticed, even if the HRD score is generated and the mutations are not detected, then also the therapy will be effective. That means the score is of very much matter, and it is generated through the testing of 3 biomarkers, which includes that mutation, telomeric imbalance, and large scale transitions. So cancer with positive HR score proven to be highly effective at advanced ovarian peritoneal carcinoma, and is highly recommended for such cases. And every second ovarian cancer affected female has HRD. That means homologous recombination deficiency. So any kind of cases, if they are presented with ovarian pathology, maybe high grade serous ovarian carcinoma, peritoneal carcinoma, HRD can be suggested for those patients, irrespective of the fact that they have family history, irrespective of the fact that they are following the conventional chemotherapy, and it is a FDA approved testing. So these are the PARP inhibitors which had been approved by FDA in past years, and we are using olaparib, niraparib, brucaparib, and various other PARP inhibitors. The one thing which need to be considered in HRD testing is it is only validated for ovarian cancer. So wherever the test is getting done, you have to understand that you can definitely send the samples for prostate cancer patients too. But for prostate cancer, the scoring, HRD score may or may not be impactful for the therapy purposes. Yes, the mutation which will be identified in the HRR pathway, whether it is germline or somatic, depending upon which kind of panel the patient has chosen or the doctor has ordered, that mutation will be definitely helpful if it will be pathogenic or likely pathogenic. If uncertain, that means uncertain consequences. But the score will not help for prostate cancer patients. So HRD is FDA approved testing only for ovarian cancers. Again, in this, if germline part is also involved in the analysis, then you have to consider risk analysis. If in family, if it comes out to be pathogenic or likely pathogenic or viewers, then it has to be correlated with the family history. And any kind of recommendation, it will be on clinician's discern. So these are the certain FDA-approved PARP inhibitors therapy. You can see in ovarian cancer, olaparib, brucaparib, niraparib has been approved. HER2, we are talking about prostate cancer, then I'll be directly talking about prostate cancer only. Olaparib, if HRR or somatic gene is positive, and rucaparib, if mutation is there. So that means it is not telling that this is under clinical trial, but you need to consider that the SCAR score will not tell you about the impact of prognosis in the patient for prostate cancer patients. It will be only effective in ovarian cancer patients. And this is HRD. For HRD, you can see eligibility is only for advanced ovarian, fallopian, and primary peritoneal cancer. If it is HRD positive, then that means FDA approved drugs, niraparib and olaparib will definitely impact. Yes, for every other cancers, including prostate cancer, trials are going on. So hopefully in the future, the HRD SCAR score will be effective for prostate and other solid cancers related to BRCA. So overall, the utility of HRR and HRD testing is it aids in making therapeutic, targeted second line therapy or as a maintenance therapy. So wherever the therapy is introduced and it is required, it impacts the overall prognosis of the patient. If germline part is there and germline testing is getting done, then hereditary risk assessment in the family can be done. And HRD is FDA approved testing for advanced ovarian cancer patients. So, and HRR and HRR germline or somatic testing can be done for prostate cancer patients. This is from my side. Thank you so much.
Thank you, Dr. Ashna. That was a wonderful presentation. So you said HRR. So what exactly we have that like if somebody cannot have the tissue in prostate,
Yes.
we cannot do the somatic analysis, right?
Yes.
So what we are supposed to do is that HRR germline is also equally good enough for these patients.
Yes, definitely. If you're suspecting that, especially if any kind of therapy which has been introduced before as a conventional therapy, if it has been done in prostate cancer patient or ovarian cancer patient also, and it is indicating like for platinum-based therapies, they are highly, in HRD patients. If it is effective basically in patients, that means we can suspect that, okay, this patient maybe he is HRD or she is HRD. So then HRR testing, if tissues are not available, then blood testing can be done to check for the eligibility of PARPI therapy. So depending upon which panel you are suggesting for HRR germline, also if any one of the mutation comes out to be pathogenic or likely pathogenic, then that patient becomes eligible for PARPI. So that can be administered.
One more thing, see, when it comes to HRD, Myriad, all those things, foundation,
Yes.
these are the FDA approved HRD testing. So what you guys are doing at core?
So okay, when we are talking about HRD, yes, as you mentioned, FDA approved the Myriad and other US based testing. At core, we have validated HRD as per our population, as per the ovarian cancer cases which we received, right? And the panels, the pipeline, the validation has been done according to our population. So maybe the SCAR score changes as per lab. So in core, if the SCAR score is more than 50, because we have seen in ovarian cancer patients that SCAR score more than 50, in them PARPI was more, it was more therapeutically indicated or effective. So at core, whatever validation we have done, our team has done, we present the SCAR score, and the same genomic instability biomarkers are getting checked, but the score differs. So even in India, if you're sending to different labs also, you need to check with the pipeline and the team that what are the scores, sensitive score that they will be presenting. Yeah. And in core, what we are doing, not only germline and somatic part is involved, but also MLPA. So the BRCA MLPA, 6 to 12% of cancers can be BRCA mutated, and it can be only detected by MLPA. So in our HRD testing, which are getting done in core, it's a comprehensive profile. You don't have to go for BRCA MLPA separately; it will be included in that also.
Great. Thank you so much for that, and thanks for that wonderful presentation. With that, we'll move to the next session, sponsored session by Bayer. I would like to welcome Dr. Kiran, who is a consultant medical oncologist at JSS Hospital. He'll be talking on management of metastatic hormone-sensitive prostate cancer. Dr. Kiran, over to you.
Yeah, thank you, sir. Shall I share the slide, sir?
Please, yes, sir, you can share your slides.
Is it visible, sir?
Yes, they are visible. Please just make it full screen. Yes, sir, you can start.
Yeah, good evening, everyone. Thanks, Srinivasa, for the opportunity for today's talk. Thanks, Bayer. The slides has been sponsored by Bayer. Today's talk is regarding darolutamide in metastatic HSPC. That is the overall topic is regarding this study where we combined triple agent in the treatment of hormone-sensitive prostate cancer, metastatic, that is ARASENS trial. So the treatment of prostate cancer has evolved over years, where initially there was only androgen depression therapy was there. Then later in 2000s and all, we then started adding one more agent, that is androgen receptor inhibitors. Then later, now after adding this androgen receptor inhibitors to the ADT, now the time has come to add one more agent where there is a increased response, prevention of further progression of hormone-sensitive prostate cancer to metastatic CRPC, and to extend the overall survival as long as possible by giving a high magnitude treatment for high-risk patients and high-volume patients of prostate cancer. So we'll go through this is the disclaimer, and my presentation goes on these topics where the rationale for the combination of darolutamide, we'll study about the ARASENS trial, and then the defining the ARASENS patients, that is regarding volume analysis and also risk analysis, different high volume and low volume, and also in high risk patients and low risk patients, how this combination works. And the last regarding the backup, that is ARASENS in low volume and low risk data. So why we should combine darolutamide only in ADT with docetaxel? Because there are many other drugs like darolutamide, just like apalutamide and enzalutamide. So why darolutamide should be combined with ADT and docetaxel? So this is the reason, because extending survival, delaying progression to metastatic CRPC, and preserving the long-term quality of life. These are the key treatment goals in patients where we start with the treatment for metastatic HSPC. One is prolonging survival, because metastasis is associated with high lethality, particularly in patients with high volume hormone-sensitive prostate cancer. The second one is, as soon as the patient goes in CRPC, if the patient lands up in CRPC at a very short period, that indicates a poor prognosis, and that reduces the time to the next anti-neoplastic therapy. And once again, when we give a lot of drugs for a metastatic HSPC, the quality of life is of utmost importance for all these patients, and that impacts the disease and also the long-term treatments. Now, why docetaxel? Because of distinct mechanism of actions in docetaxel. So docetaxel, as we all know, it's a microtubule inhibitor, where docetaxel freezes the cancer cells in the M1 anaphase and arrests the M1 anaphase, whereas darolutamide is a potent androgen receptor inhibitor. Androgen receptor inhibition blocks the nuclear translocation of the androgen receptor, preventing growth, that halts the cell cycle between G1 and S. So this chemotherapy works at M1 phase and darolutamide works at G1 and S phase. So they can both act synergistically when they are added together, when they are given together. In vitro and in vivo studies have shown that targeting the AR with an AR inhibitor enhances the efficacy of cabazitaxel, but here docetaxel can also has the same role as both belongs to the same group. In this study, we have combined in the next slide, we can see whenever we use docetaxel along with the darolutamide, that has proven the efficacy and tolerability benefits in a low potential for drug-drug interactions, because when you compare the other drugs of just like apalutamide and enzalutamide, that can impact the other chemotherapeutic agents by inducing the enzyme CYP3A4 substrates, so that decreases the systemic exposure of the taxanes. So concomitant treatment with the docetaxel and enzalutamide has resulted in 11.8% reduction in geometric mean docetaxel exposure. In pharmacokinetic crossover studies, simultaneous administration of cabazitaxel and enzalutamide has resulted in 22% reduction, but that doesn't happen with darolutamide. In the graph, as we can see, the concentration of docetaxel remains the same in both the arms, whether we give darolutamide or not. The concentration of docetaxel remains the same throughout the period. Now coming to the ARASENS overview, this is the trial, ARASENS trial. This is the only study to date which is designed and powered to provide a compelling evidence of overall survival benefit versus when placebo is added to a doublet therapy with ADT with docetaxel. The patient profile is metastatic HSPC with the performance status score of less than 1, and candidates for ADT and docetaxel. Further stratification was done between M1A, M1B, and M1C. As we all know, M1A is non-regional lymph node, M1B with the skeletal metastasis, and M1C with visceral metastasis. and alkaline phosphate levels whether less than or more than upper limit of the normal. So the randomization was done 1:1 between the two groups, that is docetaxel plus ADT plus darolutamide was added in the first group, and darolutamide placebo was given the second group instead of darolutamide. The endpoints for the primary endpoint was, because it is a metastatic disease, it should be overall survival, and secondary endpoint with like other agent, other parameters, castration-resistant prostate cancer, time for the patient to progress to CRPC, and time to pain progression, symptomatic skeletal event-free survival events, and we can see so many secondary endpoints, and also the safety of the patient. The final analysis was conducted after 533 deaths, and secondary efficacy endpoints were tested hierarchy. So as you can see here in this column, in this table, we can able to see the patient characteristics between both the arms were equally matched. And also the Gleason score at the initial diagnosis, whether it's less than 8 or more than 8, whether it comes to high risk or low risk, has been equally divided between the two groups. And also metastasis, whether M1, M0 or MX, and also the alkaline phosphatase levels, everything is matching between the two groups. And one more important thing is, all 3/4 of patients in adolescents had high volume disease, and 70% has high risk disease. So as you can see here, Gleason score of more than or equal to 8. Maximum number of patients were present, that is 505 patients were there out of 551 in the first group, and out of 654 patients, 516 patients were there in the second group. That is more than the Gleason score more than 8. That comes to high risk category. So the primary endpoint is the overall survival, where we can see a clear-cut separation of the graphs between the two arms with a hazard ratio of 0.68. Patients' 4 years survival rate increased from 50% to 63%. Clear-cut, there is 13% benefit when darolutamide was added to docetaxel plus ADT when compared to the placebo. So the risk of death was reduced by 32.5% in the darolutamide arm. And secondary endpoints, where the time to CRPC is of utmost importance, secondary endpoint, because that adversely affects the patient's overall survival and also the quality of life, and further second lines of other treatment. So when we combined darolutamide with ADT and docetaxel, there was a clear-cut separation of graphs here also, with a hazard ratio of 0.36. Only 0.36, and the median time was 19.1 months, and it was not evaluated in the other arm. And also time to progression, here also there is a clear-cut benefit with the darolutamide arm. So other clinically relevant secondary endpoints were significantly improved by the darolutamide combination with docetaxel and androgen deprivation therapy. Darolutamide for ADT with docetaxel improved the rate of undetectable PSA levels. As long as the PSA levels goes undetectable, that indicates a good prognosis and good efficacy of the drugs. So more than twice the number of patients in the darolutamide arm achieved undetectable PSA at any point of time. Even at 24 weeks, 36 weeks, and 52 weeks, we can see a clear-cut decline in the PSA levels going for undetectable levels. And at any point of time, definitely darolutamide has got a benefit when combined with the docetaxel and ADT. So here in the post-hoc analysis, undetected PSA at 24 or for 36 weeks were associated with improved overall survival for patients treated darolutamide plus ADT with docetaxel. So overall, darolutamide has got a overall survival benefit and also a benefit in secondary endpoints, including time to CRPC and detecting the undetectable PSA levels, achieving undetectable PSA levels. Now coming to the side effects profile, where the side effect profile between the two arms were quite comparable between the arm A and arm B. And also the discontinuation rates were quite similar. If you give darolutamide or not, the discontinuation rates were quite similar. The median treatment duration of darolutamide combination was almost 3.5 years versus less than 1.5 years for the placebo. So all including grade 1 to grade 5 adverse effects were quite similar between the two arms. So it doesn't have much impact when darolutamide was added to the backbone of docetaxel plus ADT. And the most common adverse events were similar between the two arms. As you can see, the fatigue, vasodilatation, and flushing were all common between the two groups, but the rashes were more common in the darolutamide group. But when it was compared after the exposure, the rate of adverse events of special interest was similar between the two arms. So the low rates of adverse events were associated with the ER pathway consistent with well-established tolerability profile because of the similar side effects between the two groups. And most of the side effects, what we saw in the groups, that is alopecia, neutropenia, and fatigue, all these are because of the docetaxel, because these side effects were more prevalent during the initial phases where docetaxel was given, and later it reduced once we stopped docetaxel and continued with only darolutamide and ADT. Now, the same data, Arason's data was studied in 4 groups, that is high volume and low volume groups and high risk and low risk groups. So the information regarding the number and sites of metastasis were prospectively collected in case report form to allow for a disease or risk assessment for all patients enrolled in study. The high risk and low risk were as per the charted and latitude study, and also the high volume and low volume in the same study. The efficacy wise, when compared to the placebo plus ADT, it has got a clear-cut reduced in the risk of death by 32.5% and delayed progression to CRPC and improved other clinical relevant endpoints. It resulted in undetectable PSA, as we saw in the previous graphs, which is associated with improved survival. So it also maintained the quality of life because all the side effects were similar to the two arms. There is no hidden extra increase in the grade or severity of the side effects when darolutamide was added to the group. So darolutamide is quite a safe drug which can be added to the backbone of chemotherapy plus ADT. And most of the side effects were present initially during the docetaxel period, and once docetaxel was stopped, thereafter reduced progressively. So it does not affect the ability of the patient to complete the full 6 cycles of docetaxel. So given the unique structure and clinical and drug-drug interaction profile, that is, there is no increase in the CYPC, no drug interactions, and the overall drug concentrations remain the same, the results of Arasen should not be extrapolated to other second-generation androgen receptor pathway inhibitors, just like apalutamide or enzalutamide, which can inhibit the CRPC and that have got more drug-drug interactions. This is a volume analysis where darolutamide was analyzed between the high volume and the low volume group. As we all know, high volume group were defined as the patients having more than 4 bone metastasis, including apart from the vertebral levels, and also if the patients are in visual metastasis also. And who are patients not fit for high volume group were taken for the low volume group. Here also, as we can see in the chart, majority of the patients were in the high volume group in the darolutamide arm. So majority had bone metastasis with high volume group that is more than or equal to 4 bone metastasis, and visual metastasis were also there. So patients with high volume HSPC has got more than 30% reduction in risk of death, which is consistent with the overall population as we saw earlier. So when we substratified the patients with the high volume group, then also darolutamide has got a significant benefit of 30% reduction in the risk of death. In the smaller volume subgroup also, the results were suggestive of an overall survival benefit with a hazard ratio of, here in the high volume group, the hazard ratio of 0.69. As we can see here, all the points were towards the left, which is favoring for darolutamide. The overall survival benefit of high volume population consistent across all the subgroups, including de novo and also in recurrent cases. Here, as we can see, 432 patients were de novo and 158 patients were recurrent cases. Here also, there were a number of events were 191 in the de novo group and 21 in the recurrent group, favoring the addition of darolutamide.
Sir, kindly conclude your...
And the darolutamide combination also delayed disease. Yeah, it's consistent with overall survival. It has got a benefit with addition of darolutamide. And the drug discontinuation was also quite similar between the two arms, so it doesn't affect the treatment period. And also the side effect profile was similar between the two arms, high volume or low volume. All the side effects were similar. There was no increase in any of the side effects. The efficacy, as we saw earlier, there is more than 30% reduction in the risk of death. So the standard of care is the new standard of care with the darolutamide, where there is more than 30% risk of deaths or reduced, and with the darolutamide, and also the delay in timing of CRPC. The same was seen in the risk analysis also, where patients were stratified for high risk and low risk patients, where high risk was if the PSA was more than or equal to 20, and also the Gleason score of more than or equal to 8. So all these high risk patients also got benefit with the darolutamide when darolutamide is combined with docetaxel and ADT. So as you can see here, the drug discontinuation and the side effect profile were all similar between the two groups. And here also, in the high risk population, also there was 30% reduction in the risk of death and also delay in the CRPC. And also, it was also similar in the low volume group, where all the patients, including the high volume and low volume group, it has got a benefit. In the low volume groups also, there was a clear-cut separation of the curves where darolutamide has reduced the risk of death when added with the docetaxel and ADT. So as you can see in the graph, in this plot, where all the parameters favor darolutamide when compared to the placebo. So exposure-adjusted incident adverse effects were all similar between all the risk population and all the substratified groups. So summarizing the thing, summarizing my topic, darolutamide has got an overall survival benefit, has got clear safety profile, no drug-drug interactions, and also the same side effect profile when compared to the placebo. So it's quite a safe drug when we give. So 30% risk of reduction death is there when we added darolutamide. Thank you.
Thanks, Dr. Kiran, for that very lucid and nice presentation. If there are no questions, we'll move to the next topic. It's a case-based discussion by our very eminent speaker, Dr. Avinash, who is a senior consultant at Clear Medi, Radiant Hospital, Mysuru, a very good friend of mine. Dr. Avinash?
Yeah, good evening, all of you. Technical team, can you share my slides? There is some problem with my laptop.
Yes, sir. 1 second.
Dr. Avinash, you can introduce the panelists.
Yeah. I mean, actually, first of all, I would like to thank Dr. Srinivas for giving me opportunity to be a part of this absolutely wonderful meeting. Actually, the slides which were given to me were little off because I had the panelist in the form of surgical oncologist as well as radiation oncologist. So I thought I would change the slides as well as put into basics of management of non-metastatic prostate cancer. The previous slide, please. So actually, the main concept here, what we want to discuss is management of metastatic hormone-sensitive prostate cancer. What Dr. Kiran has already mentioned about the use of darolutamide or the triplet combination therapy in metastatic hormone-sensitive prostate cancer. We are going to come to the end of our panel discussion to specifically talk about the ARASENS trial. Right now, we will be talking about the basics of non-metastatic prostate cancer. Next slide. So my panelist would be Dr. Naveen Anvekar from Apollo Hospital, Mysore, Dr. Kiran PK from JSS Hospital, Dr. Vijay Kumar, who is surgical oncologist in Bharat Cancer Hospital, and Dr. Vinay Kumar is again radiation oncologist from Bharat Cancer Hospital. I have clearly divided questions based on the panel. So first, this question goes to Dr. Vijay. Based on your day-to-day practice of prostate cancer management, so what percentage of prostate cancer seen by you in the metastatic versus non-metastatic, just roughly to give an idea?
Hi, Dr. Avinash.
Hi, yeah.
Actually, I went through your slides. Like I discussed with my MRD department. So out of around 2,500 new cases, we are seeing roughly around 60 or 70 prostate cancers. Okay. In that, majority are like almost 80% are metastatic only. So because of less awareness and actually it's not a notifiable disease as such. So we are seeing more of metastatic prostate cancer in our settings.
Probably this is because a majority of us are working in a specialty hospital where we only look into cancer patients. So usually these early patients will be landing up in urology OPDs. So that's why probably we may not be able to see a lot of non-metastatic. But anyhow, one of the Globocon data which from India actually, which highlighted the percentage of new cancer patients of prostate, they divided into castration sensitive versus castration resistant. And they mentioned that almost it is 50-50. So 50 patients out of 150 patients will be castration sensitive, and castration resistant will be 50. Out of those castration sensitive, again 50 will be metastatic, 50 will be non-metastatic. Obviously, CRPC majority will be metastatic. Only around roughly 7 to 8% will be non-metastatic. So this is the rough idea about the patients we do see across India. So when it comes to non-metastatic, if you see a patient, so how do you approach?
Dr. Avinash, whenever I see non-metastatic patient, basically I want to examine completely, like physical examination in the form of rectal examination to see any like nodularity infiltration. We could be able to find out through clinical examination. Then I will subject him for prostate-specific antigen (PSA), and obviously trust-guided biopsy. We don't do blindly now. And then basically the main treatment approach is based on two things, like life expectancy. As everyone knows, we have to assess the life expectancy, and risk stratification. Whether the
Yeah,
patient
I'll come to that. Okay, so basically you want to evaluate completely and then explain the patient about further management. So diagnostic part as well as the part about the management. Next slide. So to Dr. Vinay, this was about the Dr. Vijay's continuation. So how do you stratify the patients in non-metastatic CA prostate? Basically, it is the main part in the management or deciding factor for treatment of prostate cancer.
Definitely, sir. As you said, when it comes to non-metastatic CA prostate, based on the T stage, PSA levels, and Gleason score, NCCN stratifies non-metastatic prostate cancers as very low risk, intermediate, and high risk and very high risk. So these are the initial risk stratifications, pre-treatment risk stratifications, which would definitely help us guide us in further treatment.
Just to ask the same question as Dr. Vijay, how many of the patients you see in being a radiation oncologist in non-metastatic setting?
Non-metastatic, as you mentioned from the Globocan data, like most of the times we see very lesser chunk of patients that will be non-metastatic, and like say 50-50%. I mean, most of the times it will be, even if I see a non-metastatic, it will be a high risk or a very high risk CA prostate that I witness most of the times.
Okay, thank you. Next slide. So this is to Dr. Naveen. So you are working in a multi-specialty hospital now, and any case of prostate diagnosed by your urologist will be definitely one opinion will be taken by you. So for all patients, you advise PSMA PET-CT nowadays because of its availability, or you want to do a classical conventional investigations to rule out metastatic disease?
See, most of the studies which have been done, they have not included some PSMA PET-CT scan, or this an older studies and all. So it was based on CT scan and bone scan itself. And for the localized what you call prostate cancer with very low risk, I don't recommend PET-CT scan. For intermediate and high risk, you can do either CT scan, this one thorax, abdomen, and pelvis with bone scan or PET scan, because I don't want them to go for two modalities of what you call evaluation. I usually recommend them for PSMA PET-CT scan, but because the sensitivity and specificity is slightly higher compared to the CT scan and bone scan.
The problem with the PSMA PET-CT would be because, as you mentioned, the majority of the studies have not included PSMA PET-CT, and with the availability, I think all my panelists would agree that majority of the patients will undergo PSMA PET-CT nowadays. And if you find one or two sites of metastatic here and there, would the treatment be changed?
No, the treatment will be based on what is there on the CT scan of the PET-CT scan rather than this PSMA uptake. If the CT scan shows no other metastasis, but the patient should receive localized treatment with radiation if required.
Very nice. Okay, I think any discrepancy or a change in opinion from other panelists? No. Next slide. So Dr. Kiran, I think we'll come to the main part, androgen deprivation therapy in non-metastatic. So, I mean, we know the theory. So which one would you prefer? If there are no financial constraints, nothing. So which and how long? How do you decide upon that?
In a non-metastatic setting, we risk stratify the patients between low, intermediate, and high risk. If the patient is having an intermediate low risk, then just observation on this thing. And if the patient is having intermediate risk, I would prefer going for a degarelix. For intermediate risk, I will go for some 6 to 8 months of ADT. And for a high risk patient, around some 2 to 3 years, will continue. And
If
ADT.
patient asks, sir, whether I should take for 2 years or 3 years, what would you answer? Because this is what I have experienced. Majority of the times we start degarelix, patient completes radiation, PSA will be under control. They finish 2 years. At the end of 2 years, they will ask whether I should continue for 1 more year or not.
I'll go for 3 years, sir.
Okay, so definitely, to err on that side, obviously we go for the maximum duration if patient has tolerated well, and as I mentioned, there are no side effects or good
no financial constraints also.
Yeah, obviously financial constraints. Yeah, and how do you select GnRH analog versus GnRH antagonist? So degarelix versus leuprolide.
Not of much difference between the two, except for that flare phenomenon with GnRH analogs. And almost there's a clear data that there is both are non-inferior, both are equal.
Any selection based on the side effect profile?
Yeah, except for the flare phenomenon.
Okay, and Dr.
And
Naveen,
also
I think
one study where they found that the injection site redness and all will be more with GnRH antagonists like degarelix when compared to GnRH analogs. Apart from
also,
that,
I think I've read that probably some cardiovascular side effects will be more with the
GnRH analogs.
So where already patient has cardiac clear-cut morbidity and the ejection fraction is low or something of such sort, probably
in those cases
more of
we'll go for antagonists.
Yeah. Next slide. Again, coming back to Vijay, so when do you advise, though it is very rare in your practice, so when do you advise surgery for non-metastatic patients, and what would be your method of choice, whether it is available in your center or not?
Dr. Avinash, unfortunately, we don't have that setup in our institute. Actually, in a radical prostatectomy is the gold standard treatment for localized non-metastatic prostate, provided if life expectancy is very good and there is no comorbidity. Actually, initially, open methods they used to do, there was a lot of concern about bleeding, nerve injury and all. So now with the availability of robotic surgery, I think that should be a gold standard thing in localized non-metastatic prostate cancer.
So you categorize them into risk stratification, no? So for all risks, you want to advise surgery or any specific?
Only intermediate or high risk will, and non-nodal diseases.
Okay.
So, and many studies have shown, like compared to other thing, surgery is bit better in terms of like incontinence or any bleeding thing or nerve injury.
If specifically patients ask whether the radiation is better or surgery is better, what would you
definitely suggest the surgery is better.
Okay, so next slide, I will put to the same question to Dr. Vinay. When do you advise RT and how do you decide? Being radiation oncologist, when do you send the patient for surgery versus you want to keep them and give radiation? Dr. Vinay.
Sir, advising radiotherapy, I would recommend radiotherapy for low risk, intermediate, high, and very high risk. In all these risk stratifications, radiotherapy is recommended. And to suggest or to help out the patients, we don't have any head-on trials to compare radical prostatectomy versus radiotherapy. And it has been shown that both of them are equally effective. In that way, I would give an option to the patient in terms of radical prostatectomy versus radiotherapy and the pros and cons of both. Most of the times, if you ask me, when it comes to radiotherapy with a multiparametric MRI, if the neurovascular bundle is involved, then probably I'll be a little hesitant to take it up for radiotherapy because patient might end up with incontinence. Otherwise, I will be good to go ahead with radiotherapy. And of late, it has been shown that moderate hypofractionation, because prostate radiotherapy would go months together before with the conventional fractionated radiotherapy. Of late, with moderate hypofractionation, we can bind it up in 20 days. In that way, with a good technical support, where if the IGRT is available, then definitely I would recommend radiotherapy for all the patients of low risk up to very high risk.
Because both are almost equally effective. Yes, please. Yes.
Mainly it depends on where the patient lands up, whether to surgeon or radiation.
So it depends. But what we should ideally do is, I think we should counsel them
Counsel
together.
Correct.
Counsel
I
them
feel that
together.
both-
Sitting
both-
both radiation oncologists and surgical oncologists should sit together and counsel the patient, telling about and answering them the queries they have got. Ultimately, I think we can give the ball keep the ball in their court only.
Their court.
I think that would be
Definitely.
better.
I feel that both the options should be given to the patient.
Yes.
And also the role of ADT comes here.
Yes, please. Yes, Dr. Naveen.
3 years of ADT with surgery, we can avoid that, I feel.
With surgery, radical
Only-
prostatectomy, you don't want to add ADT?
Only if the patient undergoes archaectomy along with radical prostatectomy.
Only in that case. Otherwise, if patient undergoes radical prostatectomy, I mean, definitely ADT should
ADT
be
is yes, sir.
a part
ADT
of
is
treatment. Yeah.
Yes.
Okay. Next slide. I mean, metastatic HSPC patients, when it comes to only the androgen deprivation therapy, what we are talking. So, what is your approach? I think we have discussed about triplet. So, practically, what you do, whether you only do ADT plus one drug, or you want to add docetaxel, and what are you doing as of now?
I usually approach the patient based on the what you call this one volume load, based on this one chartered trial or this one latitude trial. And if the patient is young, fit, and the volume is high, I usually go for triplet, abiraterone based triplet based on the peace trial, I think. And if the this one volume is low, I usually go for doublet.
Have you used any triplet as of now?
Yes, I have used triplet.
With darolutamide?
No, with abiraterone.
Abiraterone, docetaxel, and ADT.
ADT.
Okay. No. I mean, patient could tolerate any specific side effect, because we have been discussing about side effects, safety, everything about darolutamide.
We had to reduce the abiraterone dose. Both all the 3 patients, I reduced the abiraterone dose to 750.
Okay.
Yes.
That's a nice thing. Okay. Next slide. I think this is the same question. I think we have got the ADT alone, ADT with androgen receptor pathway inhibitor, androgen ADT with docetaxel, which usually we don't use in this scenario. And the last option would be ADT, darolutamide, docetaxel. I think out of those, even darolutamide, along with that, I think as Dr. Naveen mentioned, abiraterone is also a part of treatment which has been mentioned in various guidelines as category 1. Next slide. The same question will go to Dr. Kiran. I think the second question, evidence for best possible approach. I mean, apart from whatever the trial you mentioned, any evidence that out of these ADT plus the 3 drugs which are approved, ADT plus docetaxel, which abiraterone versus darolutamide, or ADT alone. So, which would be the best possible approach? Obviously, there are no head-on comparisons.
Depending on the data, personally, I don't have any much of experience with the triplet treatment, because I have not used because of the toxicity. Most of the patients will have comorbidities and old age patients. So in these cases, I have used only doublets, ADT with abiraterone. But given this data, recent data, I'll be more prompted to use a triplet regimen in young fit patients with high risk disease and high volume disease.
So basic dictum is high volume, high risk, and high risk, high volume, and fit patient. We are going to go with triplet. Otherwise, I think the ADT with one of the drugs, enzalutamide, apalutamide, or I think abiraterone would be fine.
Abiraterone or darolutamide.
Yes. Next slide. The same question. Next slide. Dr. Vijay, I mean, what is the definition of MHSPC according to you? Metastatic hormone sensitive. Obviously, de novo patients will be considered as MHSPC. Other than that, do you find any other category of patients? Dr. Vijay? Dr. Vinay can answer if he is not there.
Hello.
Yeah.
As name suggests, it's like the metastatic disease which responds to hormone thing. It may be synchronous or metachronous. Even like metachronous also are included in HSPC.
Metachronous means?
Like after the duration, after the treatment. If
patient has undergone definitive RT or prostatectomy and completed the androgen deprivation therapy, again patient presents with metastatic.
Yeah, or it may be high risk or high volume disease based on whether it is visceral or number of bone mets. We can classify like that.
Okay, right. Next slide. Any role of definitive RT in metastatic HSPC, Dr. Vinay? We mentioned about only ADT and the combination of ADT. So have you used RT?
So just a follow-up answer for the previous question. I feel anything other than CRPC would be a metastatic hormone-sensitive prostate. I'm like the rest, all the thing would fall into sensitive prostate CA, I guess.
No, there is what is known as metastatic CRPC as well.
That's what,
Metastatic
sir.
CRPC.
Other than CRPC, probably whether it is patient has received androgen deprivation, whether it is naive to the
Yeah, that's what. Yes,
therapy or
yes,
not
yes.
naive to the
Correct.
endocrine.
Absolutely.
When it comes to metastatic hormone-sensitive prostate cancer, I would definitely recommend local radiotherapy to the prostate if the metastatic burden is very low. Stampede trial has shown that biochemical progression-free survival is much better when we give local radiotherapy to the prostate, especially when the burden of the metastasis is very low, say less than 5 metastasis, apart from visual metastasis.
So definitely, even we have used, but only one question for me is, whenever you are using definitive RT in such patients, obviously you are using ADT. Whether you want to add one more drug, or you want to keep ADT alone, or you want to add one more drug.
During radiotherapy, sir, only ADT. I would recommend only ADT. Post radiotherapy, probably you can add a doublet as per your convenience, as per your choice.
Okay. Next slide. I think this is about Arasens trial. I think we don't have much time. We have discussed in detail with by Dr. Kiran about the Arasens trial, the various inclusion exclusion criteria, why the combination of docetaxel and darolutamide were better than any other androgen receptor inhibitor, and also what were the secondary endpoints like time to CRPC, time to pain progression. These were also important, and the value of PSA, which was undetectable in certain patients. So these were the secondary endpoints which were very important, and the safety. So I'm going to skip this slide. Next slide. Again, this is about the Arasens trial. So just one question to Dr. Naveen. Because Dr. Kiran has already mentioned, how do you see Arasens trial?
Yeah, because it has had all the treatment goals. This one tick, like prolonged this one overall survival, delay progression to this one metastatic CRPC, and preserve long-term quality of life with a good safety profile. I think it is a way to go forward, I feel.
Okay, so then what we discussed was only in high-risk patients we are going to use triplet. So because the Arasens trial showed very good benefit with low-volume disease, whether you want to include, and based on the safety profile, well-tolerated drugs. So whether you want to include in low-volume disease as well?
No, mostly it is a trial for high volume disease, because 77% were high volume disease, and low volume, I think it was a bit underpowered to say, though this one survival advantage was to the tune of 30% here also. I would preserve this regimen for high volume diseases.
I would agree. Kiran, do you agree the same, or you want to?
I agree, sir, because as in the data, the low risk disease was only 30% of the patients.
Correct.
So it was only a low burden data. So better to preserve it for high risk disease.
Okay, next slide. I think this would be my last slide. Kiran and Naveen both. Because it's the session has been sponsored by the Bayer, which is the main manufacturer of darolutamide as of now. So where do you put exactly darolutamide in MHSPC or non-metastatic CRPC? If there are no financial constraints, you want to use upfront when compared to other androgen receptor inhibitors?
Yeah, definitely. Darolutamide can be used both in non-metastatic and metastatic HSPC in treatment-naive patients because of good, means there is no drug interactions, better tolerability, no drug discontinuations. All these things, I would put it in the first-line treatment for non-metastatic as well as metastatic HSPC.
Naveen?
Yeah, I would agree with what Dr. Kiran says, but the thing is, darolutamide, how long, and the cost issues? is a question I feel.
That would be solved by Bayer or the one's patent is over. Okay, let's discuss in some other forum about the financial constraints. Anyway, I hope I finished in time. I thank again all my panelists, and I thank Dr. Srinivas once again.
Thank you, sir. Thank you.
Thank you, Avinash. Thanks all the panelists for that wonderful interactive session. As always, Dr. Avinash justifies his job by doing a wonderful moderation, as always. Thanks for that wonderful presentation. With that, we move on to CRPC. Dr. Avinash enlightened about hormone-sensitive prostate cancer part. We will now welcome Dr. Guru Prasad, who is going to talk on metastatic CRPC patients management. Dr. Guru, are you there?
Hi, I'm there. Can you share my slides, please?
Support team.
Hi. On the outset, I would like to thank Srinivas and the whole team for giving me this opportunity to speak on this topic on CRPC. Am I audible? Am I audible?
Yes, Guru. Yes, Guru. Go ahead.
Okay.
Your slides are also
next slide. Thanks, Srinivas. As we know, prostate cancer comes to us pretty late. It doesn't come that early for us. It's first the urologist and then all other treatments and then comes to us. Yeah, even then, prostate cancer has a very high incidence and very high mortality also. After lung, the second most common cancer is prostate. And mortality is also pretty high compared to lung. It's around the fifth most common mortality. The mortality may be because of MI. Next slide. The most common histology is adenocarcinoma, but there are other histologies which gives us a lot of headaches. The most common one being the small cell type. Next slide. And the problem there is we know the stages of these cancers, stage 1, 2, 3. I'm not going to the details of it. Next slide. What we are looking is the symptoms also. I think we know the symptoms commonly, that is either difficulty in urination, frequent micturition, or passing blood in stools, or pain because of radiculopathy, or these are some of the symptoms. Next slide. We know the biomarkers, the PSA. My slide starts with the metastatic CRPC, so I'll go next slide. It's a very good marker. PSA is a very good marker for follow-up of patients on CRPC. So there may be doubts for screening, but definitely for follow-up, it's in a patient with diagnosed prostate cancer, PSA is definitely a marker to go ahead. But now we have multiple treatment options. Initially, from the era of only one single drug to docetaxel, to cabazitaxel, to Enza, to abiraterone. Now to the era of olaparib, rucaparib, and even PD-L1 inhibitors. It's a huge change. And next slide. So CRPC, we know that the testosterone levels should be less than 50 and patient progressing. It's a huge gamut of diseases. It's not just one disease. So CRPC can be just the PSA rising and patient having absolutely no mets, or patient having multiple bone mets only and PSA rising, or patient having bone mets, visceral mets, and PSA rising with the testosterone level being less than 50. So a CRPC trial head-to-head comparison of 2 or 3 trials may not be the same, because we need to see what different subtype of patients they took, whether they took only the bone mets, whether they took only the visceral mets, or they took only patients having PSA biochemical rise. So there lies the problem of comparing 2 or 3 trials. We have trials comparing olaparib, rucaparib, talazoparib available. So that there lies a problem, just for saying that CRPC is a huge bundle of diseases. Next slide. So CRPC basically means it is not androgen independent. It still means that there are pathways which have taken over. even with the blockade of testosterone in the body, that is either either doing surgical or medical orchidectomy. And the pathways in the tumor have taken over these, and they can be AR resistant, AR mutation, increased AR ligand synthesis, ligand independent AR activation. Now, why all this is important is now in the present era, molecular era, there's a mutation AR7 which we need to which usually indicates a progression on abiraterone or enzalutamide. If they progress, this mutation occurs, and that means that you cannot give the other molecular drug, drug in the same path. In the sorry for the phone ring. So AR mutation we can check in a patient who has taken one of the hormonal pathways. We can check it. So if the patient has taken abiraterone, whether to give enza or not, we can check this mutation and then say that, okay, these patients, you can't give the same hormonal drugs. We have to change to a different line of therapy, like either chemo or BRCA or PDL1. So there lies the importance of knowing where this mutation occurs. Next slide. And the most common mutation, if we see a mutation, up to 10% of the patients on CRPC have some mutation. In these 10%, majority of them, 5% will have BRCA mutation, around 4.4% will have BRCA mutation. So BRCA2 is the most common mutation which is seen, and remaining 5% have all other mutations. Now, the most other common mutation is ATM1. Now, the problem is we have gone from germline mutation to all other mutations which you can do. HRD is there. It is not the same. Olaparib working on BRCA2 is not similar to olaparib working on ATM1, or rucaparib working on BRCA2 is not similar to rucaparib working on ATM1. Rucaparib works wonderfully well in BRCA2 and BRCA1, not that great with ATM1. So when we do HRD, we always see which mutation is they are taking care. And the HRD is basically for ovary. So we don't know how to extrapolate the same result to prostate. There lies a problem also. But yeah, if you are doing one mutation analysis, BRCA1, BRCA2 would be a wonderful mutation. If the patient is affordable for immunotherapy, then the microsatellite instability also can be checked for Lynch syndrome, that is MSH6, MSH2, and things like that. Next slide. So as said, BRCA2 is the most common mutation which is seen, followed by ATM, which is the next common most mutation seen. Next slide. And these are seen in up to 10% of our patients. Next slide. Next slide. We know how BRCA works, whether it is germline or somatic, and things like that. Next slide. In ovarian, in prostate cancer, it is usually we take that fresh sample from the prostatic tissue and send it for biopsy. Usually, there are two ways of testing a BRCA, that is a blood and the tissue itself. So in ovary, we do both. In prostate, we do the sample from the tissue, whereas in breast, so each cancer have their own way of testing this BRCA mutation. In prostate class, since we are dealing only with prostate, it's a tissue sample which is ideally sent. Next slide. That is a somatic mutation. Next slide. And there are so many PARP enzymes 1, 2, 3, and each of them have their different ways of action and different ways of repair of the DNAs. Next slide. So one PARP inhibitor is not equivalent to the other. That we know by when we see the head-to-head comparison of olaparib and rucaparib, the side effect profile is different, the tolerability is different. So there lies the difference between the drugs also. Some may work on one enzyme and others may work on another enzyme. Next slide. Next slide. So this has already been told, because the initial talk at 5 to 5:30 was a talk on BRCA mutation and stuff. So I don't want to go into great details. Next slide. So coming to the treatment aspect per se. Next slide. Where do we stand and what's new? What is new is we have olaparib with abiraterone coming up this year. Olaparib was already there and rucaparib is already there since 2020. This seminar has been sponsored by Merck, which primarily gives rucaparib, original rucaparib. Next slide. So they tried the classical one arm of BRCA1, BRCA2, and ATM in one arm, and versus all other HRR mutations in cohort B, and they tried to see the difference between the drugs in each of these arms. Next slide. And this classically, we know that when it is for BRCA1, BRCA2, and ATM, classically these drugs, PARP inhibitors, works really well. Next slide. So this is the slide which has been highlighted. Next slide. Next slide. Next slide. So the mechanism of action, it's a long way for us. We have seen the drug. We have used this drug. We have used the full dose. We have started reducing the dose. 600 mg/BD was the conventional dose. We have started reducing the dose also. Most Indians don't tolerate the full dose of this drug. Next slide. We need trials from India also for knowing what dose they tolerate and things. Next slide. Next slide. So the previous slide, sorry. The median relapse-free survival is around 9 months, and the overall survival is not yet mature. But usually at 1 year, around 73% of them are alive and kicking. So this is a very good drug in a prostate cancer who are having either a BRCA mutation, BRCA1 or 2, or ATM mutation. Next slide. That is what has been highlighted in this slide as well. Next slide. Now, there is this treatment 3 where rucaparib was compared in patients having BRCA1, BRCA2, or ATM alteration versus physician choice. Physician choice was either docetaxel, abiraterone, or enzalutamide and things. And in a patient having a BRCA1, BRCA2, or ATM mutation. Next slide. Next slide. And this says that definitely rucaparib holds its fort and holds its ground. It works very well in patients having BRCA mutation. Next slide. The same with the relapse-free survival and overall survival. It holds its ground. Next slide. It is a wonderful drug in a patient having BRCA mutation. It has its own side effects, the most common being weakness. Most of the patients say sustu in the first 1 month, and it subsides. Otherwise, you'll have to keep a monitor on anemia, myelodysplastic syndrome, which is a problem which we face, which we have to keep a keen eye on it. Next slide. Next slide. So there are in 2023, this was in 2020. Now in 2023, we have drugs. They have tried both abiraterone with niraparib and abiraterone with olaparib. I think trials with rucaparib also with the abiraterone is coming up. And so we see that in a patient having this mutation, it works really well. Combination drugs of abiraterone 1000 mg OD with prednisolone with a PARP inhibitor is now coming up in patients. Next slide. And even this slide says the same thing, that in patients with evenly matched, the combination works well. Next slide. So we now are going from 2 drugs to 3 drugs mutation. Classically has been as explained in this slide. These drugs, the PARP inhibitors, works very well in BRCA1, BRCA2 mutation, but not that great in other mutations. That is, for example, if you see patients with ATM or any other mutation, doesn't work classically that well. But yeah, still there's a separation of curves. But if it's a BRCA1, BRCA2 mutation, definitely there's a huge separation of curves. Next slide. Next slide. We know the side effect profile of these 3 PARP inhibitors. Next slide. So the same, they are trying abiraterone, they have tried enzalutamide with niraparib, and this now becomes a 2-drug combination again. And since initially they tried olaparib, now niraparib, talazoparib, rucaparib, all the drugs, PARP inhibitors, have been tried with enza in a patient with BRCA1, BRCA2 mutation, classically BRCA2 mutation, and they find there's a difference in progression-free survival. Next slide. Classically, the PFS, the slides separate, the curves separate, and there's a difference in PFS. Next slide. Overall survival, not that great, because prostate cancer, they usually survive really long, and there will be crossover over time. So very difficult to comment whether it's because of one of the drugs or because of crossover and things. Next slide. We need additional follow-up. Side effect profile we need to monitor. Just like initially in metastatic prostate cancer, we used to give one drug. In the 2023, we are now giving two drugs. It can be either a PARP inhibitor with the hormonal blockade. Next slide. That is what has been coming up in this era. Next slide. Thank you. So before I comment, since it's a talk on metastatic CRPC, if the patient is asymptomatic, the first line of drug is either Spicucel-T. If the patient is slightly symptomatic with bone mets itself, then the drug of choice is abiraterone or enzalutamide. If the patient has metastasis and symptomatic, zoledronic acid comes into the picture, visceral mets is there, chemotherapy comes into the picture. If the patient has some mutation, that is either a PARP inhibitor or a PD-L1 drug comes to the picture. In 2023, the trial comparing two drug regimen of a PD-L1 with another drug is a negative study, but a trial comparing a PARP inhibitor with the hormone therapy is a positive study. So this is what I would like to say. Thank you, Srinivas. Thank you, whole team, for giving me this wonderful opportunity. I didn't restrict myself just to Rukaparib. I've told everything what is possible for CRPC. Thank you once again.
Thanks, Guru. Thanks, Guru Prasad, for that nice presentation. Since we are running a little late, I'll just continue with next session. I would like to welcome Dr. Akhil Kapoor for this Merck-sponsored session on recent advances in the management of metastatic urothelial cancer. Dr. Akhil Kapoor is a consultant and associate professor at TMH Varanasi. Hi, Dr. Akhil Kapoor. How are you?
Hi, thank you. Thank you, Dr.
I welcome you for this meeting. Over to you, Dr. Akhil.
Thank you. Thank you. May I have the slides, please? So we are going to discuss about recent advances in management of metastatic urothelial cancer. Actually, a few years back, there were very little options apart from platinum-based treatment, but now there have been sudden spurt in the treatment options for urothelial cancers. Next slide. As we see, the bladder cancer was actually not very well recognized in Indian settings previously, but now we have recognized that yes, it is a significant proportion, and we do see a large number of urothelial cancer patients in our situation, and most common being 90 to 95% transition cell cancer. But yes, other cancers like adenocarcinoma, sometimes neuroendocrine cancer, these are also very well prevalent. Next slide, please. Before understanding, yes, incidence is actually very high in especially patients coming from urban areas. For example, you can see the registries in Delhi, Mumbai, and Kolkata and Thiruvananthapuram. So maximum metropolitan cities, they are reporting the maximum number of cases. But yes, the number of patients are significantly high even in other areas. Next slide. If we see improvement of treatment options, the platinum-based treatment was started from even 1970s, and first time gemcitabine got approval in 2008. Later in 2017, pembrolizumab as an immunotherapy got approval for platinum ineligible patients, and in 2021, for first time, avelumab got approval as a maintenance treatment options post platinum. Next slide. So what is the main problem associated with urothelial bladder cancer, and why we want to utilize maintenance therapy? Why we don't want to wait for second line immunotherapy options? The reason is that these patients do respond well to platinum-based treatment, especially cisplatin or carboplatin. But what happens within very short time, they progress very rapidly. And what happens that most of these patients, that is 40 to 50% patients, are not able to receive next line of therapy itself. So imagine 100 patients started the treatment, around 50 patients could not receive second line treatment itself. They progressed rapidly and were not able to receive next line of therapy. That is the main reason to utilize some form of maintenance treatment. And these are the options of therapy, either wait and watch. This is what happens if you wait and watch, and the patients will progress rapidly before initiating second line treatment. Continuation maintenance, that is start IO with chemo and then continue IO maintenance. This study has been already done and there have been negative results. Such maintenance is what we are discussing presently. Next slide. So there have been data for the same. Next slide. there have been data, for example, as I have told, IMvigor, Keynote data, all these were negative. Danu was also negative. Pembro plus Leno, all these trials were negative. So IO plus chemotherapy trial strategy has failed miserably in urothelial cancer, as against most of the other cancers, where start with IO plus chemo, like in small cell cancer, start with IO plus chemo, then continue IO maintenance. That is a preferred modality. But here, all the drugs, not only one drug, multiple drugs, Pembro, Atezo, Durva, all have failed. Next slide. So what to be done? If patients who have received first-line therapy with platinum and develop resistant and start on second-line therapy, the cisplatin-based treatment, the median OS is 14 to 15 months and carboplatin is 13 to 14 months. So we are talking about 13 to 15 months basically. Next slide. So disease control rates, though initially high, so patients are responding, but they are not sustaining the response. That is the main problem. That is why maintenance treatment is needed. Next slide. If you see the Javelin bladder trial, which was the regimen which yielded the longest median of any phase 3 trial, here you can see patients' progression-free survival after first-line therapy was close to 29.7 months. So it seems that yes, a large number of patients are surviving. Median OS is reaching very high, and this approach seems to be the most preferred approach now, because whatever approach you utilize, patients progress rapidly and do not maintain the responses. Next slide. If want to maximize the OS, that is what we are discussing. Switch maintenance approach, that is start with chemotherapy, then shift to IO-based treatment with avelumab is the preferred choice now based on the available data. And the good thing about this Javelin trial data, it is based on overall survival. So immunotherapy trial, which had primary endpoint of OS, that is very, very rare actually. And this trial was very commanding that it selected OS as the endpoint. If you see in this trial, 4 to 6 cycles were allowed. Next slide. 4 to 6 cycles of chemotherapy were allowed. And what happens? That patients become, in some patients, what happens after cisplatin or carboplatin-based treatment? Patients develop toxicities and are not able to receive 6 lines of therapy. That is why another trial is ongoing where 3 versus 6 cycles followed by avelumab maintenance is being tested against each other. But in this trial, 4 to 6 were allowed. So in my practice, I try to shift as early as possible after 4 lines of treatment, 4 cycles of chemotherapy. If the patient is tolerating the chemotherapy really well, then it is fine. We can continue up to 5 to 6 cycles. But most of the time in real practice, patients do develop thrombocytopenia and the toxicities after 3 to 4 cycles only. So the point is to shift to switch maintenance early, not to wait for a long time, because dose density and intensity is completely lost due to toxicities and patient might rapidly progress. Next slide. So this is with the preferred choices options, a maintenance approach. That is why it has become the standard treatment, and that is what we utilize regularly in our routine practice. Next slide. If we see the IMvigor and Keynote data, which are negative trials, the patients have a very short PFS and OS. So this approach is not practiced now. Next slide. And if we see, if we combine immunotherapy with chemotherapy, as talked earlier, these are not giving any overall survival benefit. So you are utilizing immunotherapy, but not getting benefit also. So that is why these drugs have failed as a first-line combination treatment. Next slide. And this is the rationale for combining switch maintenance treatment, that after debulking the disease with chemotherapy, you release the antigens into the circulation, and without waiting for the progression, you start avelumab as a maintenance treatment that is leading to best possible outcomes. That is the rationale, but this is theoretical. Next slide. So Javelin bladder hunters, everybody knows about this trial now. Patients who did not progress after the chemotherapy were given avelumab maintenance compared to supportive care alone. Point to note is here, the patients with CR were also included in this trial. And what happens, again, I will say, these patients with urothelial bladder cancer behave like a small cell. They might develop CR. Even then, these patients require maintenance treatment, else they progress very rapidly and they do fare poorly if maintenance treatment is not instituted. Next slide. And as highlighted, the primary endpoint of the study was OS. And you can see the median PFS was improved at 2 years from 7 to 23%. And at 3 years, around 30% to 36%. So 6.4% absolute benefit, hazard ratio of 0.76. And you can say PFS is also significantly prolonged. Next slide. The long-term safety profile, avelumab is well tolerated except for some initial infusion reactions. These drugs, this is very well tolerated in our practice. Next slide. And this is the real world data also, which was presented this year only in ASCO GU 2023, the trials of AVANCE, READY trial, and the multiple real world evidences have been presented to support the first line avelumab maintenance. There is no doubt actually about the benefit of this approach, and we do consider every patient for avelumab maintenance. With improved PAP program also, it has become very more affordable as well, and that is why we try to utilize avelumab maintenance in patients. Next slide. Also, if we see there is real world data from various situations, we have also published our own data that has also been presented, and also this is data from France. So multiple countries have done this real world data, and real world data is already always welcome in such trials, such studies, so that actual benefit can be documented. Next slide. This is data from Italy as well. Next slide. So this is what I just discussed, is assessing the response after 3 or 4 cycles. In our practice, actually, we do the response assessment after 3 to 4 cycles and then shift the patient to avelumab maintenance. We do not wait for completion of complete 6 cycles, but if patient is tolerating the treatment very well, it is fine to go up to 6 cycles. But in real practice, 80 to 90% patients develop some form of toxicities and are shifted to avelumab maintenance after 3 to 4 weeks. In the trial, waiting period of 6 to 8 weeks were allowed, but in our practice, we do not wait for so long. We try to start avelumab maintenance after 3 to 4 weeks of completion of chemotherapy, so that the patients are free from the toxicities of chemotherapy as well, and also are much better fit to receive any further treatment. So don't wait too long, but don't wait too short also. Making a balance is what is required. Next slide. So this is data for this which I just discussed. Next slide. Bladder 100 is actually very close to our heart. The major benefit is achieved within cycles of 4 cycles. That is what I highlighted. Radiologic response is maximum after cycle 3 to 4, and later on there is no further downsizing of the tumor. That is evident from the spider plot as well. If you see this spider plot, this tells after 4 cycles, most of the time there is no further down regulation and downsizing of the tumor. Next slide. The OS and PFS benefits are clear even with CR patients, PR or ST. So if you will think that patients who have achieved CR do not require immunotherapy maintenance, this is not the case. As highlighted, these patients also progress rapidly. Though they have achieved CR, they might progress very rapidly. That is why even in CR patients, it is very important to utilize avelumab maintenance. Next slide. So that the benefit which have attained can be utilized. So in the OS benefit is clearly evident even in patients who had CR. Next slide. And now this is with the BIS data. It is approved in all the guidelines also, ESMO, be it ESMO, ESCO, or any other guideline. The avelumab maintenance is approved even after DDM-VAC or GemCis or GemCarbo based treatment. So it is this trial included everything, GemCis, GemCarbo, and also the DDM-VAC based treatment. So that is very overall good for coverage of all the regimens which we utilize in the practice. In metastatic setting, DDM-VAC has not shown any survival advantage over GemCis or GemCarbo. That is why we tend to utilize GemCis or GemCarbo mostly in our patients. Next slide. So Asian subgroup analysis that was presented last year at ASCO GU 22, that has reaffirmed that these patients do, Indian patients and Asian patients do very well, and they have the good benefit as from the overall trial as well. Next slides. So we can just run through the slides. So these are the baseline balance characteristics. A large number of the patients were there, 70 patients, both arm in the Asian subgroup only. Next slide. And this is the data. There is good separation of the curve, 18 versus 25 months. So it is a huge number for separation. Next slide. And this is a very clear time to next line of treatment was also significantly improved from 9 months to 15 months. So yes, around 6 months benefit in terms of this is the data. So next slide. And many patients improve the responses as well. So what happens? The responses are sustained and sometimes responses are improved as well. So patients who achieved stable disease or their responses might be improved by utilizing avelumab maintenance to partial responses. That is what we see. Next slide. So toxicities, as highlighted, it is very minimal. Avelumab maintenance is very well tolerated, and we are well aware that thyroid problems and pneumonitis, and some patients developing colitis. These are well-known adverse effects of any immunotherapy, but these are less and grade 3, grade 4 occur in less than 5% of the patients. Next slide. So definitely it is advised to continue avelumab maintenance. In the trial, it was continued indefinitely. Next, see the next slide. And median PFS of 26 months was achieved in patients who were exposed to bioinitial maintenance for at least 12 months, and median was not reached. So at least 1 year or more is recommended. In the trial, it was continued till progression. Next slide. So the sequencing, the treatment is the similar. Utilize chemotherapy 4 to 6 cycles, preferably 4 cycles, then start avelumab maintenance. And if there is progression, utilize second line therapy with either therapies based on, we do NGS in our patients, adafitinib we have utilized in few patients on compassionate basis. And also you can re-challenge the platinum based treatment if there have been more than 6 months of platinum free interval. That is what we do in practice. Sometimes paclitaxel is also utilized. Other options include pemetrexed and other options which have limited data. Next slide. Thank you. And I think we have covered everything. This is what I'm talking about. Enfortumab is not yet available, but is a promising drug. And it seems that, yes, it will be available with us in the next year. Next slide. So all the treatment landscape, they are clearly suggesting of utilizing avelumab. Thank you. With this, I would like to stop here. Thank you for the patience listening.
Thanks, Dr. Akhil. That was a wonderful presentation. As you rightly said, now we have multiple therapeutic options for urinary bladder, which was not available anything before, like 4 or 5 years back. As you said, Sustumab, Govetican, and Encorfinib, all those drugs are going to be available, and these patients will have some kind of hopes. With that, thanks a lot for that wonderful presentation. With that, we'll move to the next session. Recent advances in the management of newly diagnosed ovarian cancer, the role of Lynparza maintenance, by none other than my very good friend, Dr. Mangesh, who is a consultant medical oncologist at Fortis Hospital and a transplant physician, and as well Helios Cancer Center. Hi, Dr. Mangesh.
Hi, Dr. Srinivas. Good evening, everybody.
Waiting. Over to you, Dr. Mangesh.
Yes, I will just let me share my screen. And while I am actually loading the slides, very interesting thing today, I had opportunity of seeing 2 new CA cases, and I was actually getting an opportunity to revise it with our patient today. So, but there are also some things that I learned on the way to my place while listening. So, and that's something which I would probably try to incorporate when we discuss about this very interesting topic, which we have had presentations on, but every time we actually try and understand it, it seems to give us a new meaning all the time. So is my screen audible, Dr. Srinivas?
Yes, very much.
Okay, and I hope I am well audible as well.
Yes, you are very well audible.
Thank you. So let's get started. So we are, as medical oncologists, along with our surgical colleagues, many a times are frustrated about managing CA-ORI, because initially the fruits of our work is really good. We always seem to get very good responses, and I would be surprised if we get any surprises during our treatment of CA-ORI of an upfront stage 2, stage 3 case. We usually tend to get all the best responses, then we go for a surgery, and many times we proudly get a reward from our surgical colleagues saying that they were able to achieve complete responses. The patient does really well. So if they have undergone interval CRS, we are happy to give them adjuvant therapy. And many a times after we give adjuvant therapy, we are basically following up these patients and trying to understand when the CA 125 is going to climb at all. And we are always nervous when we do the CA 125 levels. And when the CA 125 goes up, and which which it usually eventually does. Then we go for imaging, and then we have to have that discussion with the patient that despite excellent neoadjuvant chemotherapy, excellent CRS interval, and also excellent adjuvant chemotherapy, we still have a recurrence on our hand. And as medical oncologists, it's very difficult for us to always convey to our patients that out of 10 patients that we are going to see, almost 8 or 9 of them will come back with a recurrence or some sort of a progression. And we have to then convince them after they come back with a progression or recurrence that it was always going to be the case. So let's try and see if we have achieved something new in the management of all these new ovarian cancers that we have, and can we actually change the course of the disease for these patients, because it is all over the internet that CORE is seldom cured, especially if it is in stage 3, and patients many a times do ask you that question, if there anything else that we can do to keep the recurrence at bay. So I will just get started with my presentation. Yeah, so I will deal with my presentation in these 4 quick big segments: the background and what is the unmet need, the BRCA mutation role, the trials that have studied the role of olaparib in CA-ORI. So let's start with background. As I told you, almost 70 to 80% of our women relapse within 3 years of first-line treatment. And once they relapse, we are basically on that never-ending cycle of first, second line, third line, fourth line, and so on and so forth. And the good news is, despite all this, many of our patients are in a good performance status. At the same time, it is frustrating for them to come and visit us regularly. So with all that we have for a newly diagnosed case of CA-ORI, we have 5 years of survival in 38% of the patients. And that too, I would not be surprised if 90% of these 38% of patients belong to stage 1 and stage 2. So when we have patients with stage 3 and stage 4, our 5-year survival rates for those stages are usually abysmal. Then because of this outcome, we resorted to using bevacizumab, thanks to some of the data that we had that at least progression-free survival will be extended. And we got progression-free survivals of 1.5 years. And we are still not satisfied with that, because we are seeing great inroads with respect to management of CA breast and CA cervix. And ovarian cancer is definitely lagging behind with that data. And this is usually the story of most ovarian cancers. We get them at in a good performance status. Many a times they come with ascites. We do whatever we can do for these patients with first line therapy. We find that in first line therapy, the PFS is usually 1.5 years. Then second line will be 9 months. Third line will be 6 months. Fourth line will be thereabouts. And fifth line will be less than 5 months. And finally, patient lands up with extensive additions in the intra-abdominal cavity, and there is bowel obstruction. There could be severe sepsis, and then patient succumbs to any of these complications that we see. So what do we do for these patients, and what is the what are the strategies that we can do in our day-to-day practice with respect to CA-ORI and peritoneal malignancies, so that we can achieve better outcomes? So one major and very important resolution to many of our ovarian cancer patients comes in the form of BRCA status and also the HER status. And let me run these through. Most of you are very well aware of this. I don't want to spend too much time, but I would like to touch upon the salient aspects of this, and that's very important because many of us, believe it or not, even today sometimes may omit doing BRCA mutation testing. It is very well available now, and also the prices are a lot more convenient for us compared to maybe 2 or 3 years in the past. But it is important for us to remember that BRCA mutation status ideally should be ascertained for each and every patient of CA-ORI and peritoneal malignancy. So we know that it is now a predictive factor because we have the targeted therapies and 2 of them we have even generic targeted therapies. Niraparib is also on the horizon. So we should be definitely checking, just like we are checking for ERP or HER2 status in breast cancer. BRCA testing ideally should be done on every patient that we have. We know it's also a prognostic indicator alongside the stage of diagnosis. The histology and extent of surgical debulking is also very important. The risk assessment is also very useful. Not only are we helping the patient to get the best form of therapy, but also if we do detect germline mutation, we also can check for at-risk family members and also develop and provide preventive strategies that are very well accepted in the oncology world. So we know that almost 50% of our patients with BRCA mutation, whether they are germline or somatic, doesn't matter. When we check for BRCA mutation in the tissue of an ovarian cancer patient, almost 50% of them will have no relevant family history of ovarian cancer, breast cancer, or any cancer for that matter. So it is very important for us to remember this this truth, that because we should remember that checking can give us yields in such a large number of patients. We also know that 2 out of every 3 of our patients with BRCA mutation, whether it's again somatic or germline, are going to be are going to be 50 years or older at diagnosis. So if you check 3 patients who are 50 years and old, you will find that 71% of them will have a BRCA mutation. And it's very important to remember this one very important point at the bottom of the slide, that almost 40% of the BRCA mutations may be missed if testing is only performed in those patients who have BRCA mutation, who have a family history of breast cancer. And that is extremely important for us to remember, because such a large number of patients we are missing, and we should not be doing that at least today. So the guidelines are very clear now. We are very happy to offer BRCA mutation testing in the tissue for all the patients. Not only we have a high chance of picking up the tumor BRCA mutation, but also the germline BRCA mutation can then be reflexly tested on the same index patients, so that we can look whether the BRCA mutation was a somatic or a germline. Now, we know that germline mutation will be detectable in the blood test also. So when you are checking for the tumor tissue, checking for BRCA mutation in the tumor tissue, we are not only identifying the somatic ones, but also after that next step, we can look for the germline ones as well. So this slide is very emphatic, saying that almost 20% of the ovarian cancer patients have germline BRCA mutation, and almost 10% of all the ovarian cancer patients have a somatic BRCA mutation. So this makes it almost 30%. 3 out of every 10 patients will have some form of BRCA mutation, whether it's in the somatic or in the germline. And it's very important that again I wish to re-emphasize, 40% do not have any relevant family history. So there are also no particular surrogate markers. Okay, for this patient can we check, and this patient can we not check, and it makes it very useful for us to just basically give it for all the patients, and that probably is very useful for us because we don't have to rack our brains much about it. So just give me a second. Hide the video meeting control. Okay, yeah. So how to read a BRCA report? Let me not dwell on it, but we can divide them into clinically important, unknown clinical importance, and no clinical importance. Clinical important, it's a very emphatic yes that you should consider them to be pathogenic, but there are going to be surprises in this class 3 uncertain category, because some of them have some data and some of them do not have any data. So I wish to emphasize that unknown clinical importance or class 3 mutations should be probably discussed with the molecular biologist, so that we do not miss on any of these mutations. Yeah. So again, clinical decision making should not be based on a VUS, and we should discuss it with our colleagues in the molecular biology. And if the molecular biologist is very emphatic that this is not a pathogenic mutation, then only we should probably give it a blind eye. But if in doubt, I would rather treat these patients or treat them rather than saying that this is not a very great significance to us. So again, I'm repeating the same slide. Presence of pathogenic or likely pathogenic BRCA mutations. Interpretation is that these patients have a high predisposition. A variant may or may not be clinically relevant. It's up to us to actually discuss and make sure we discuss with the patients. Absence of BRCA mutation, as I told you, it does not matter after that. Of course, we'll have to delve into the HER status, but as much as possible, we need to have discussions with the molecular biologists when we have a negative disease. So the take-home message is test all the patients. Make sure you make timely clinical management and make sure that you start with the tumor BRCA testing. If they are pathogenic variants, please discuss it. And remember that all this is extremely important. This is not just information. If the patients are positive for BRCA, olaparib has led to substantial improvement in PFS. So it is important for us to test it. So let me jump into the data that proves that our BRCA testing helps the patients through the therapy that we provide for them. So let's start with this. With these studies. These studies are very important. The schema is very, very clear. There is not much controversy in it. Any newly diagnosed ovarian cancer, irrespective of the surgical outcome and carrying a BRCA mutation, usually will have surgery upfront or has an interval cytoreduction therapy, and followed by that, if the BRCA mutation is positive, as it is in the case, then we prefer to provide olaparib maintenance to them. Again, the same thing has been extended, that if there is a patient with newly diagnosed ovarian cancer, irrespective of the surgical outcome, the patient could be a tumor BRCA mutation positive. And if it is a non-tumor BRCA mutation positive, we check for HRD positive status or HRD negative status. This study actually included the HRD positive status determined by the Myriad My Choice genomic instability score of more than 42, but it would be only considered as HRD negative if the score is less than 42. So it is to be remembered that these studies are indexed on the Myriad My Choice CDX genomic instability scoring. So it has to be interpreted with caution. Not every test can be probably applied to these inclusion criteria, but we will consider that it has been done for all the patients and we'll continue discussing the data. So in the SOLO-1 trial, patients who are newly diagnosed with stage 3 or stage 4 high-grade serous, endometrioid, primary peritoneal or fallopian tumor with a tumor BRCA mutation, germline or somatic, good performance status, and with the intention to perform a cytoreductive surgery, were stratified into olaparib 300 milligrams twice daily and placebo, and the stratification was done in 2:1 randomization, and they were also stratified based on response to the first line platinum based chemotherapy. So the stratification would be whether they achieved a complete response or a partial response of the after the platinum based chemotherapy. Post the treatment with the chemotherapy, these patients should be randomized, and during the randomization, they would be studied for one, the efficacy, that would be progression-free survival and overall survival. Second would be time from randomization to first subsequent therapy. That means you would be changing the therapy from either olaparib or placebo to second line chemotherapy. Last but not the least, the quality of life also was very closely studied. So the treatment would be given for 2 years, and it would be stopped after 2 years if patients did not show any radiological evidence of disease. And patients with a partial response at 2 years could continue treatment. And how long you could continue, it was not mentioned, but it was continued indefinitely in this case. If this partial response patient later on had a NED or a no evidence of disease, then there was an option to discontinue the treatment in these patients. So the primary endpoint was an investigator-assessed PFS, which would be cross-checked by using a blind independent review, and then overall survival, time to first subsequent therapy and the second subsequent therapy, HRQL, all were studied. So the baseline characteristics are very well balanced. Just to keep very clear, after chemotherapy, they saw almost 80% of the patients having complete response. Rest of them would be partial. Performance status was very well divided. The FIGO stage, location, the CA125 status, the histology, all were equitably distributed amongst both the arms. The BRCA mutation study was also equitably divided in both the arms. So with very good, well-matched baseline characteristics, these patients were then studied for how many of them underwent upfront surgery. Almost 60% of them went to upfront surgery. The rest of them went to interval cytoreductive surgery. Surprisingly, there was also 1.5% of patients who did not undergo any surgery. Thankfully for us, even the placebo arm contained good number of patients who did not undergo surgery. So if you see the residual macroscopic disease, again, it was very well matched. Interval cytoreductive surgery outcomes are also very well matched. So this gives us very good baseline characteristics with which we can probably deduce the data. So if you see across the two arms, you will find that the discontinuation of olaparib occurred in 40% of the patients before 2 years, as opposed to 70% in the placebo. In the case of placebo, the discontinuation would probably be because of second-line therapy, and even for that matter, in olaparib also. Almost 50% of the patients in olaparib arm complete the treatment at 2 years protocol, and they almost 15% of the patients continue treatment beyond 2 years. So again, the data is very good, and it is very clear now to understand that almost 48%, let us take 50% as a good number, 50% of the patients who were started on olaparib maintenance remained progression free at 5 years, and 20% of the patients who completed first-line platinum therapy and were put on placebo remained progression-free. This this constitutes a hazard ratio of 0.33, extremely significant according to me. Whether there is a word like that, I don't know. But if you look at it in the sheer numbers, if 100 patients were to progress on placebo, only 33 patients would progress on olaparib. That means you have saved 67 patients from progressing by using the olaparib, and that itself is very significant. The median progression-free survival was almost close to 5 years. At least 50% of the patients remained progression-free at 5 years, as opposed to around 14 patients who remained progression-free with placebo. So the PFS2, the TSST, that is the time to first subsequent treatment, all of these parameters were studied, and it was emphatic that the hazard ratio being even less than 0.5, 0.46, and 0.46 respectively showed that there was very good benefit with olaparib. The overall survival, which was a secondary endpoint, did not. The final results are yet to be out, and so we will get most likely overall survival benefit also, but that is a secondary endpoint. So it is to be remembered that at 7 years, DCO, the clinically meaningful overall benefit was observed with olaparib versus placebo, and you can see that 67% at 7 years were alive at 7 years versus 46.5%. It may be argued that it is better to study at 10 years. I agree with that. So let's wait for the data at 10 years as well to understand how well the separation of the curves is maintained. One thing is very clear: if you see between the curves separating at 5 years to 7 years, the separation of the curves is widening. So, and it seems to be continuing to widen, or at least remain the same distance between the placebo and the olaparib arm. So I would not be surprised if our overall survival data at 10 years is also pretty much in lines with the 7-year-old data. So the common is, we are all aware of olaparib. I'm sure many of us have used olaparib in our patients, initially original, and now we are also treating with the generics. But it is very easy to see that most of the side effects are predictable. If they are identified at grade 1 and grade 2, we should ideally not have grade 3. But nevertheless, we do sometimes get situations, and due to which we are forced to come down on the dose of the olaparib. So my takeaway messages, as per the SOLO-1 trial, it is just remember it very clearly. Maintenance olaparib is a standard option for maintenance in responding CA-ORI patients, with 70% reduction in risk of progression after we complete first-line therapy. And the overall survival data is also significant. There is no significant decrease in the quality of life from baseline, and we are very happy to continue this patient. Sometimes may require dose reduction, but in general, very rarely do we see any permanent discontinuation due to adverse effects. Last but not the least, let us go for Pollard 1 trial. So this trial addresses the scenario in which if we cannot put the patients on olaparib because of the BRCA mutation or absence, what do we do in those patients? And it is very important for us to understand that while 40% of the patients are 40% of the patients are going to be 30% of the patients are going to be positive for the BRCA mutation, either germline or somatic, there will still be a significant percentage of patients who will not get olaparib based on the BRCA mutation status. That is where we need to understand if there are strategies where we can still utilize PARP inhibitors or not. So the study goes that very similar to the schema to the Solo 1 trial, except that there was allowance for using bevacizumab in these patients, and once they achieved a CR or a PR, they would be maintained with olaparib added to bevacizumab in the study arm and bevacizumab with placebo in the control arm. And the stratification was done 2:1. Good number of patients were recruited into the study, and bevacizumab dose was 15 mg per kg. So it should be remembered again that there is hardly any difference in the primary and the secondary endpoint as compared to the Solo 1 trial, but there was pre-specified exploratory endpoints, especially with respect to the tumor BRCA mutation status as well as the myriad my choice CDX score status. So this is very important, and this is what will help us with the Paula 1 trial outcomes. So very important thing to remember is that this was a study which told us that we should not just check for the tumor BRCA status. Of course, it should be studied first, but in case if it is negative, then we should still chase the HRD status, of which BRCA may not be a part of, by doing a myriad my choice testing, by which we can study the genomic instability score of the patient, so of the patient's tissue. So it is very important for us to remember, and we have had multiple discussions on this in various forums. I will not touch into the depth of it, but it is very important for you to understand that the HRD status also is very important when it comes to sensitivity to platinums as well as the PARP inhibitors. The study was very well balanced. The baseline patient characteristics were well balanced. Hardly much to differ between the both, and they had good number of patients who underwent upfront surgery and good number of patients who underwent interval cytoreductive surgery. And even with respect to RECIST criteria based disease progression, the characteristics was very similar in both the arms, and it is to be remembered that disease progression was the most common reason for discontinuation and not the adverse events that are known individually for olaparib as well as bevacizumab. And it's important to remember the median duration of treatment. That means 50% of the patients were treated with 17% of the patients were treated with olaparib and bevacizumab more than 10%. So the PFS curves are very, again, emphatic. The hazard ratio is around 0.59. That means that patients who received only bevacizumab, if they achieved 100 events, the olaparib and bevacizumab arm, they would achieve 60 events. That means 40 instances of progressions would be avoided by the usage of olaparib and bevacizumab. So the median PFS translated into 22.1, almost touch and go to 2 years, versus placebo and bevacizumab, which was less than 1.5 years. So the median time from first cycle of chemotherapy to randomization was around 7 months. And the investigator assessed PFS would always be cross-checked by the blind independent review. So it's very important for us to know in which of these groups we had challenges of using the olaparib and bevacizumab. Actually, if you see the plot, you will find that not many scenarios precluded the use of olaparib and bevacizumab. So across all the variables, except for probably the partial response variable, where there was a touch over of the confidence intervals in the side of placebo and bevacizumab, almost all the patients who were in CR or there was no evidence of disease seen, they had very comfortable confidence intervals and very good hazard ratios as well. So treating the non-BRCA mutated patients, almost 50% of the patients in Polo 1 were HRD positive. Now imagine, we have tumor BRCA mutation in around 29%, we have HRD positivity in around 48%. If you put the numbers together, we are looking at almost 80% of the patients who will actually have some form of, a targetable genetic, phenotype. So it's very important for us to remember that 29% HRD positive, 48%, and also if you look at the genomic instability score being 42, you are seeing that a large number of patients can actually be provided PARP inhibitors, and they will all be scientifically justified as well. So it would be recommended to do HRD positive testing for all the patients, because when you saw the key subgroup PFS data, you'll find that in the HRD positive patient, and these would be determined by either tumor BRCA mutation positivity or the myriad MATRIX genomic instability score being more than 42. The median PFS was almost 19.5 months. And you will find that in the tumor BRCA mutation status, it is 15.5. So in a way, by using the bevacizumab along with olaparib, your HRD positive status patients had a better PFS compared to the tumor BRCA mutation, which is representative of the solo one trial result. And the hazard ratios for both the scenarios would be around 0.31 to 0.33, which are almost similar to each other. And so it makes us very it makes us very confident of recommending the combination of bevacizumab and olaparib. Earlier, this combination was very difficult to use because of financial issues, but now I'm sure with the improvement in the costs, we should be able to use this, and it should be beneficial for our patients. So if you see the separation of the curves, again at 2 years, this is the point I have for 2 years. After 2 years, you'll again see that there is actually a consistent and a widening separation of curve, which makes us confident of the fact that once the results of control are achieved, the control will be continued. The median PFS with olaparib and bevacizumab was around 36.5 months, almost 3 years, and with placebo and bevacizumab around 32.6, with the hazard ratio being comfortably 0.78, which is again very good for a result for a patient with CA ovary. So the addition of the olaparib to bevacizumab enhanced the clinical response to first-line treatment, and the response rate were highest in those patients who are HRD positive, as shown here. 64% HR, almost 2/3 of the patients responded with the combination. And you will see that of the patients who have responded, the maximum number of patients would be in CR, which is again extremely notable, and that should actually give us confidence in suggesting our patients to go on the same. And secondary endpoint being OS, you'll find that 65% of the patients will live for more than 5 years. And that again is a good number of patients' lives that we have saved with this combination. Definitely significant. And we need to remember that while OS is better, the 5-year-old PFS is better, it seems to be pretty consistent across each of the categories. Now, last slide, which I want to also basically study upon is, can we use it on those patients with HRD negative patients? And now the data on this is clear. If you are using olaparib versus bevacizumab and placebo, the survival is hardly any different. The hazard ratio is probably worse because of the usage of olaparib and bevacizumab. So in these patients, we can safely avoid recommending, and we need to probably look at other strategies to recommend for these subset of patients. So it is pretty well tolerated. We only need to be cognizant of the early side effects that we have at grade 1 and grade 2. If we are able to go through that phase where we are tweaking the dose of the medicines for the patients, after dose adjustments, we will find that it is not such a difficult drug to actually use. However, we have to always tell all the patients on PARP inhibitor that there is a small, minor chance of developing a second malignancy somewhere in the future. So I will not run through much of this because we already studied this in the Solo 1 trial. But this is something very important. We have to know that some new malignancies may happen in those patients. And so they need to know while we are starting them that it is possible on the long run that a very small percentage will get malignancies. There is no difference in the quality of life. It is confirmed in the Pavlov
Dr.
trial.
Mangesh, due to time restriction, I will request you to conclude.
I'm done. It's my last slides. So the take-home message is Pavlov 1 is the only phase 3 randomized study and to investigate the addition of PARP1 inhibitors and bevacizumab. The HRD positive benefit patients are as benefited as the BRCA mutated positive patients are, and the overall survival is also significantly improved. It is a well-tolerated drug, and even though you have used it in first line, even if the patient progresses while on olaparib and bevacizumab, it is seen that the benefit of PFS that was seen with olaparib and bevacizumab in first line is maintained beyond the first progression. So these are the standard dosing guidelines for olaparib, and we all have experience on using this drug, and I am sure that we are going to be wiser with the in the future. Regarding this, because of the fact that drug is a lot more accessible today, and we will definitely have a lot more experiences to share about this. Thank you very much to the organizers, Dr. Srinivas and the entire team for accommodating all of us together and making sure that we are having such delightful conversations over recent data. Thank you very much again.
Mangesh, I have one question. So,
yes, Abhay. Yes, Abhay.
If a patient is for neoadjuvant chemotherapy,
yeah.
So HRD positive, BRCA negative, what is your preferred maintenance? Olaparib or Ola plus Bev? Because anyway you can't.
HRD positive and BRCA?
BRCA negative.
So my preferred is olaparib and bevacizumab in these patients.
No, but bevacizumab you can't give all 6 cycles. No, only 3 cycles you are able to give. First cycle you can't give. 1 cycle before surgery you can't give. 1 cycle after post surgery you can't give. Only 3 cycles you are using. Only happy with that much?
Yeah, I'm fine with that. I'm fine with that.
Rabbi, what is your question? What do you want?
Yeah, I'm fine with that.
It means according to the study they use all 6 cycles followed by maintenance.
Correct. Correct. So
if your patient is for neoadjuvant, so first cycle anyway we can't use because we have to do HRD testing, and 1 cycle before surgery we can't use again. So because you have to give a time. So again post surgery first cycle we can't use. So we are using only. So we are using inadequate dosage of bevacizumab. No, 3 cycles.
No, see, so it didn't matter whether you use bevacizumab during your neoadjuvant or adjuvant therapy for those patients. Of course, adjuvant the question doesn't arise. But even if you did not use bevacizumab in the neoadjuvant setting, you could still use this. You can use bevacizumab with olaparib in the adjuvant setting and also in the maintenance setting. That's what I am given to believe with the data. So if you may have used 1 dose, 2 dose, or 3 dose, depending on the surgical requirement. But even if you're not used, you can still apply the data because this patient is HRD positive.
No, but data is 6 cycles with
you can continue to use bevacizumab with the olaparib in the adjuvant setting.
But the data is 6 cycles chemo plus bevacizumab followed by bevacizumab.
Not necessarily. If you see the data, if you see, you could have got around 3 doses of bevacizumab. It is not mentioned that all 6 cycles they have to receive bevacizumab. Around 3. If you see the initial treatment, they have said around more than 3 cycles of bevacizumab. Now, whether you use that in the adjuvant setting or the neoadjuvant setting, that has not been mentioned, because many patients would have undergone. Many patients would have undergone only 3 cycles of neoadjuvant, and it is natural that we don't give bevacizumab once in the cycle preceding the surgery. So it is recommended that 3 cycles given. It can be we should ideally use bevacizumab, but we could use it in the adjuvant setting also. So they have not said when we have to use it. Is it only in the neoadjuvant setting, or is it it can also be used in the adjuvant setting? So personally, the way I see it is, okay, even if I go to a scenario that okay, only 1 cycle of neoadjuvant was used, in the adjuvant setting, I would use the other 3 at least other 2 doses, and still the patient falls into the inclusion criteria of the Pavlov 1 trial. This is my understanding of this.
That's right. I think because since the maintenance is the one which takes care of their issues. The catch is the maintenance is the one which is actually going to benefit. That's what the whole Polo is all about, or the Solo one. The maintenance therapy is the one which pulls their survival or PFS or the OS. The benefit is maximum with the maintenance. I think it doesn't matter whether how many cycles we would have given neoadjuvant. I agree with you, Mangesh. Abhay, are you?
No. Even maintenance with single agent also has shown benefit, no? But not
Correct.
in HRD positive, but in HRD positive, niraparib has shown.
No, you're talking about Polo one?
Yeah.
See, Polo one HRD positive patients had a significant benefit, right?
Definitely, but what I told is that since we are only able to use 3 cycles, no, is it okay with that? I asked just.
I think it should be okay. Even for that matter, if you go in detail with Paulo, 20% of the patients had suboptimal cytoreduced surgery. 20% of the patients had suboptimal cytoreduction. Even
That is one of the indication for bevacizumab.
Absolutely. I think if there are no questions, I think we'll end this session and we'll move on to the next session. Case-based discussion on management of patients with relapsed ovarian cancer. My friend, Dr. Naveen Anvekar, who is a consultant, senior consultant, medical oncologist at Apollo Hospital, Mysore. Dr. Naveen, you can introduce your panelists and start the session.
Yeah, Srinivas. I thank Dr. Srinivas for giving me this opportunity. Is my slide visible?
Yes, sir.
Yes.
It's visible.
Okay. I'll be conducting a panel discussion on relapsed ovarian cancer. My esteemed panelists are Dr. Sai Vivek from Aster Hospital, consultant medical oncologist from Aster Hospital, Bangalore, Dr. Abhay Kumar, consultant medical oncologist from Manipal Hospital, Bangalore, Dr. Rachan Shetty, consultant medical oncologist from AJ Shetty, from AJ Hospital, Mangalore, Dr. Guru Prasad, consultant medical oncologist from Mangalore, and Dr. Vijay Kumar, consultant surgical oncologist from Bharat Cancer Hospital, Mysore. The case is a 65-year-old female patient with a known history of hypertension and no significant family history, diagnosed with a high-grade ovarian cancer. The patient was stage 3C and was treated with neoadjuvant chemotherapy of 3 cycles of paclitaxel and carboplatin. Patient underwent optimal optimal surgery, optimal cytoreduction, and received 3 more cycles of adjuvant chemotherapy at a different hospital. And the patient's BRCA status was not known. And patient didn't receive any maintenance treatment, was kept under follow. And after 7 months, patient on this one routine for this one, routine follow-up checking, the CA-125 was around 600, and CT scan abdomen showed recurrent disease. So Dr. Sai Vivek, what are the other tests do you want to do?
I would definitely like to do BRCA1, BRCA2, if possible, HRD on the surgical sample that we would have available. And that would be the test. Now we know it is more than 6 months, so we'll have to take it as a platinum sensitive, though 6 months to 1 year, there is that intermediate group. So 7 months platinum sensitive, I would like to do HRD if possible, or at least BRCA1, BRCA2, because the role of HRD in relapse setting is not very clear. So BRCA1, BRCA2.
Well taken. Any other test you want to do?
At this point, I think CT scan, CA-125. I'm happy at this point.
Okay, fine. Dr. Abhay?
What is the histology?
High-grade serous histology.
I think that's much on that.
Okay, thank you. And I came across this slide in CCO Oncology, the current guidelines for this genetic and tumor molecular testing for epithelial ovarian cancer. For recurrent disease, they suggest testing for BRCA1, BRCA2, HRD status, molecular this one MSI repair, tumor mutational burden, and this one folic acid this one receptor alpha, because there is a new study with drug this one conjugate with this one MIRV, this one Mirasol study, which is approved, and other tests like RET and NTRK gene this infusion, though we are not doing it in routine practice. And Dr. Rachan, would you like to extend platinum-free interval by giving any chemotherapy for this patient?
In my practice, if they are beyond 6 months, I don't. But if they have come within 6 months, if they're platinum resistant, then I would use liposomal doxorubicin.
Okay. You also answered this in second question also. And the data showed that using gemcitabine, this topotecan or doxorubicin and PEG-related liposomal doxorubicin to extend this one has not shown any overall this survival benefit. So patients who are platinum sensitive, unless there is contraindication, should be started with platinum-based doublet regimen. So for this patient, which drug combination would you like to choose? Dr. Guru Prasad?
Thing is the scenario itself. This is a classical Ayushman Bharat scenario, Paclitacarbo and then follow up and then they come back. In Ayushman Bharat scenario, the first thing he asks a surgical oncologist whether it's operable. The first thing, even in recurrence, we'll ask them if it's operable and how small is the recurrence or how bad is the recurrence. That's the first thing. Since there was no discussion on surgery, I thought let me put surgery also up front. The second thing is in our scenarios, we usually put a maintenance of 2 or 3 drugs, that is tamoxifen, endox, and methotrexate. This is a common scenario which we put. So now in the second line scenario, it's platinum sensitive recurrence. In Ayushman Bharat, we'll definitely go with another platinum. The choice based on the side effect profile, diabetes or non-diabetic, and things like that. And Rachan has picked up PEG lipodox. I'm also okay with PEG lipodox with or without bevacizumab based on the affordability.
Okay.
Since being with a platinum sensitive recurrence.
Okay. Dr. Sai Kumar, your opinion? Sorry, Dr. Sai Vivek?
Yes, sir. So I would agree with Dr. Guru, sir. I would pick up, I think, based on the patient's other comorbidities, I'm okay with either all 3 options I'm okay with based on the patient's comorbidities.
Okay. Anywhere you will be liking using single agent treatment?
Not in a sensitive relapse, not in a platinum sensitive relapse. This patient has 7 months duration between her last treatment. So unless she's very frail and she can't tolerate a doublet, my to-go would be a doublet plus bevacizumab based on the data we have available.
Would you like to take surgical opinion?
Yes, definitely. I mean, there is data from the desktop too also, but depends on what is the performance status again and what was the upfront stage and what is the recurrence right now. Definitely take up surgical opinion also.
Okay, well taken. And Dr. Vijay Kumar, any role for secondary cytoreduction? Dr. Vijay?
I think Naveen, Dr. Vijay has not joined, I believe. He left for some emergency. I think one of the panelists can answer that.
And Dr. Abhay?
So if the according to the desktop, there is a PFS and OS benefit is there, secondary site reduction. If patient meets all criteria like performance status is 0, or ascites is less than 500 ml, or previously patient underwent optimal site reduction. When patient meets all these criteria, and the disease should be able to operate. So it is only limited to abdomen. So it is operable disease. Then definitely there is a role for secondary cytoreductive surgery.
Okay, yeah, good. So this is based on a desktop this one trial, and where the patient in the first line this one relapse, the patient who where all the 3 factors were present, it was deemed as AGO score positive, and the factors were echo performance score of 0, and no this residual disease after primary surgery, and absence of ascites. And patient with this score, AGO score positive, around 75% of this patient were able to complete resection. So 2 out of 3 patients underwent total complete resection, and this is based on desktop 3 trial. Patients with all this factor for this one first relapse with recurrent ovarian cancer and AGO score positive, they were randomized for the saturated operation followed by this platinum-based treatment, or for without surgery, the patient were randomized to this chemotherapy, and with this surgery, there was no increase of any mortality. There was no detrimental long-term side effect of additional surgery, and it also showed this PFS benefit over only chemotherapy of 4.4 months, which was statistically significant, and also showed this overall survival benefit with a median overall survival of 7.7 months. And the effect of surgery was limited to patients where the what called the complete resection was done. And also the level of CA-125 had a very important factor, as you can show in this one slide. Patients were randomized based on patient was stratified based on CA-125 level less than 35 to 350, and more than 350. And as you can see, the patient who had less than 35, this value of CA-125 level, the complete resection rate was 83% versus 53% where the CA-125 level was more than 350 level. So, Dr. Rachan, any role for maintenance treatment? Hello, Dr. Rachan?
Yeah, maintenance treatment, if you have used bevacizumab, we can use bevacizumab as a maintenance. If HRD positive, then use HRD positive, then use olaparib as a maintenance.
Dr. Guru Prasad, your opinion?
In second line maintenance, a lot of drugs are there. One is, as Rachan said, bevacizumab, definitely if not used upfront. Even though olaparib, PARP inhibitors are indicated in first line, if they are not used in first line maintenance, we can try in second line maintenance. Even other drugs also can be tried. I think one more drug is which is given in maintenance is a sarcoma drug that is not getting the name of the drug. Anyway, I'll tell it later. 3 drugs are there. 2 drugs we have discussed.
Okay. In this trial, this PARP maintenance was not given in the first line in this patient. Hello, Dr. Sai Vivek, your opinion? Which one?
Yeah, I think definitely first option, if BRCA or even HRD is positive, it would be a PARP inhibitor. If not, bevacizumab.
If you are choosing PARP inhibitor, which PARP inhibitor?
I think now we have data for Solo-2 also, which is very strong. So if BRCA1, BRCA2 is positive, definitely olaparib would be my go-to drug. And if not, if HRD is positive also, I'm okay to read with all the data combined. I wouldn't use a combination as a maintenance. I would definitely use only a PARP inhibitor.
Dr. Abhay?
So if I use bevacizumab, definitely I will continue only with the bevacizumab. If I not use the bevacizumab, so even its platinum sensitivity itself is a surrogate marker for BRCA-ness, so that if patient is responding to second line therapy, partial response or complete response, even I consider for PARP inhibitors, if not use first line, if not use bevacizumab.
Okay.
Naveen, the other drug which I wanted to say was pazopanib. Sorry, this is also a drug which has shown PFS benefit like bevacizumab. It has similar PFS benefit, but it has not been highlighted by most of the studies. Similar benefit like bevacizumab. If the patient doesn't want to take bevacizumab maintenance, pazopanib also gives a similar maintenance.
Is it okay? It was new to
because of the cost effect.
Yeah.
Just one point, yes. I think recently there's been an update saying that once we used to use platinum sensitivity or response to second line platinum to choose a PARP inhibitor. But now I think the recent data shows that unless BRCA1, BRCA2 or HRD is positive, there's no OS benefit to that. Any take on that from all the panelists?
There is actually a detrimental effect. If you don't have a BRCA mutation and you do in a non-selected patients, they live shorter compared to placebo. That's
yes, and they said, and we cannot take platinum sensitivity as a marker.
But
He
but
used
the
to take,
withdrawal,
yeah.
but the FDA withdrawal, the detrimental effect has been seen in the third line, not in the second line. Third line and onwards.
Okay. Okay.
FDA
It is
has
what
removed
my
it from second
understanding.
line. Okay, FDA has removed it from second line, third line, except first line maintenance. The maintenance
Yeah.
only in first line.
Yeah, I will come across those studies. And these are the drug combination which can use. I already mentioned those. And this is bevacizumab with platinum-based treatment for recurrent ovarian cancer. We have seen in the OCEAN trial and GOG trial. It has shown a PFS benefit. And we can, and if the patient has responded well to bevacizumab with this treatment-free interval of more than 6 months, based on this Pito Mango trial, we can retreat the patient with bevacizumab. And the key trials for PARP inhibitor maintenance for platinum-sensitive ovarian cancer. The SOLO2 this study, they included only patient with BRCA mutation only, either germinal or somatic, and it showed a PFS benefit. And the NOVA's trial with niraparib, they include all comers, and they showed PFS benefit across all the groups. And the Ariel 3 trial with rucaparib, which included all comers, it showed a PFS benefit in all the 3 groups. But the data on median overall survival was available, only the patient with SOLO2 trial showed a median overall survival benefit, and patients with NOVA and Ariel 3, they showed what are called slight survival benefit with patient with BRCA positivity, and showed a detrimental effect in patients with HRD plus and non-BRCA group. And and a phase 2 study called Study 19, including olaparib for all comers, it showed a slightly improved PFS benefit in all comers and median overall survival benefit in all comers. So based on this one, the FDA has removed the approval for rucaparib and niraparib in patients who are not BRCA positive, and olaparib can be used for all comers now. But the European association has continued with approval for all the 3 drugs for all comers. And this is the recommendation. The drug olaparib can be used for the patient with BRCA mutation, wild type HRD positive, and BRCA wild type HRD negative also. But niraparib and rucaparib, as per FDA, should be used only with patient with BRCA mutation. And
so it means that platinum sensitivity we can consider as a BRCA.
Yes, to some extent. And here in this case, our patient received a combination of paclitaxel, carboplatin, and bevacizumab. And coming to the second case, a 68-year-old female diagnosed as CA ovary stage 3C and started on neoadjuvant chemotherapy with paclitaxel, carboplatin, BRCA negative, had a good response. And patient underwent interval cytoreduction and 3 more cycles of paclitaxel, carboplatin, and then the bevacizumab maintenance was given. And within 5 months, CA125 levels started rising to 300, and the scan showed peritoneal disease. Dr. Sai Vivek, how do you want to take this one, and how do you define refractory and resistant disease?
I think at this one, she underwent an optimal cytoreduction, right?
Yes.
Yeah, so if she underwent a cytoreduction and now within 5 months, there's a rise in CA125 and image documented peritoneal disease. So I would take it as a platinum resistant disease, which we do see some patients behaving like this. And at this point, I would go for lipodox. And though she has been on bevacizumab, I would, because of the peritoneal disease and probable ascites, I would continue.
Hello. Am I audible?
Yes, sir, your voice is audible. I think Sai Vivek sir is muted now.
Okay.
Oh, I'm sorry. I think there was just a technical glitch. Yeah, I would go for single agent lipodox along with bevacizumab for this patient. Peritoneal disease and ascites, I would do a combination of single agent plus bevacizumab in this case.
Abhay, any role for this and PARP maintenance in this case?
See, I don't think POP maintenance any role in this patient. But if patient anyway, I don't think it is a platinum sensitive disease. I don't think there is any role for POP maintenance.
Okay. And this one, whether which patient is platinum resistant, which patient is platinum this one sensitive, is really very difficult to define based on that 6 month this one what to call term. And the patient who progress during chemotherapy are usually categorized as platinum refractory, and who relapse within 6 months are usually referred as platinum this one resistant, and those who relapse after 6 months are usually categorized as platinum sensitive. But there are many factors which influence this factor. Maybe this BRCA-ness, the histology, this type of follow-up. If you follow up means every 6 months or every 3 months, and the patient falls in between these this one, it is really difficult to make out when the patient has progressed. And also the use of this maintenance. Usually the what to call the treatment-free interval is usually prolonged, and also what to use is also depending on the quality of life and the patient's performance status. So this one European this one oncology group, this one gynec group, they were not satisfied with this terminology of fixing the this one terminology of platinum refractory if they are less than 6 month platinum free interval, because many patients who are this one PFF more than 6 months, they also don't respond to platinum. Only around 45 to 65% of them respond, and many patients who had this one PFA of less than 6 months or 3 to 6
Dr.
months.
Naveen, kindly conclude in next one.
Around 30% of them respond to platinum. So they categorize the new treatment based on a patient who for whom the platinum might not be the best option, and the patient whom the platinum might be the best option. So among this one chemotherapy, what will be your option, Dr. Rachin?
I would choose pegylated liposomal doxorubicin, followed by gemcitabine.
Okay. And Dr. Guru, if there is recurrence with CA-125 only elevated, this one biochemical this one relapse,
we can wait and watch, or start our age-old tamoxifen, methotrexate, or endoxin, something like that. No active second-line chemo drugs.
Okay.
Age-old tamoxifen is also okay, but yeah, asymptomatic CA-125 elevation, we can wait and watch.
Okay.
The other questions: malignant bowel obstruction, conservative management, recurrent ascites, either tapping or give another line of treatment which has not been used. Since we are running short of time, I thought I'll answer all this.
Yeah, thank you. And I thank all the panelists for the wonderful this one explanation. Yeah, thank you. Back to you, Srinivas.
Thanks a lot. Thank you.
Thank you, all the panelists. Thanks, Dr. Naveen. You have put a really good effort to make this case discussion very fruitful. I would agree with you. And it's a wonderful moderation. Thanks for that wonderful moderation.
Yeah, thank you.
That will conclude that ovarian gynec session, and we'll move on to the next session, hepatobiliary session. So I welcome Dr. Satish, Senior Medical Oncologist, HCG Bangalore, to join us and he's going to moderate a case-based discussion on management of advanced biliary tract cancer in the current era. And Dr. Satish will be introducing the panelists. I think Dr. Guru is already there. Dr. Naveen, you can also join the panel. Dr. Naveen.
Thank you, Dr. Srinivas, for a kind introduction. I think my slide is visible, Srinivas?
Yes, sir. It's visible.
Okay, just 1 minute.
Sir, I think Dr. Rajiv has not joined.
Yeah, I think like Dr. Rajiv is going to join. Dr. Abhilash.
Dr. Abhilash is there, sir.
Srinivas, I saw Guru is there, and Rakshit.
Srinivas is there, not
Mekhala is there. Mekhala is joined.
Mekhala is joined, I believe.
Okay. Thank you, like Srinivas, giving opportunity to share this one of the moderate this session on hepatobiliary system, the biliary tract tumor. Raju is going to join or not? Just I wanted to have a confirmation.
No, I don't think so. I don't think so.
Okay. Yeah, I welcome my panelist, Dr. Abhilash. He is from Bharat Mysore. Dr. B.J. Srinivas from HCG Bangalore. Dr. Guru from Bangalore, dynamic person. Okay, is inspiring many of us. And Dr. Rakshit, surgical oncologist from Bangalore. Mekala, Dr. Mekala, radiation oncologist from Mysore. I hope it is a short time actually that we're having at 20 minutes. Let's have a discussion on management of hepatobiliary tumor. Let me begin with just for to begin the that context of today's talk. Like we know that the biliary tract tumors it is common in India. It is almost like nearing 32 patient new cases, including gallbladder tumor. We'll see majority, I can say almost like 90% they're all diagnosed in an unresectable stage or advanced stage. But we know current standard treatment, what we have jumps is like it is a fit person. In the non-fit person, it may be single agent or maybe supportive care also. The survival generally falls less than 1 year. 5 year survival rate is definitely, it is emerging in a very few that cases. But definitely that we can see that there is a trend in increase in the incidence of both male and female. We can see a lot like more number compared to the male. Coming to the in India, among like North India is one of the highest incidence of gallbladder tumor. You can see here, left side, you can see that this is the incidence of gallbladder tumor. You can see in various countries. India is almost like nearing 21 point for 1 lakh of population. You can see Chile is one of the highest, and Japan you can see less number. See total number of cases, annual incidence, and it's increasing. But like we try to see that more incidence in the female. It is ninth most commonest cancer in the female in India. Coming to the that question to my panelist, like Dr. Abhilash and surgical oncologist, like to begin with everyone, like how is the caseload in your like do you see common like hepatobiliary tumor in your OPD and inpatient, Dr. Abhilash? Just like we have a less number of like a less like a few number of panel also is there, less time is there. One on word we can is enough. Do you see commonly or like that's what
Sir, no.
Dr. Abhilash?
Hi, sir.
No.
Hi, sir.
Less. Hi.
Thank you for
Srinivas?
the opportunity. Sir, we see very less patients, maybe 3 to 4 patients per month, including both gallbladder and cholangio.
Okay.
And mostly we see, sir, metastatic gallbladder cancer at our center.
Okay.
Yeah, with a poor socioeconomic status. And as you know, performance status will be very poor, maybe PS 2 to 3 most of the times. And most of the cases are advanced, not amenable for resection.
Okay. Do you see like at least at least yearly 1 or 2 patients of resectable adjuvant or neoadjuvant, something will see in your
Yeah, yeah, sir. We hardly give adjuvant completely resected
Okay.
patients. So maybe 2
Yes,
to 3
yes.
cases.
Dr. Srinivas, Vijay, what is your like?
Yeah, most of the cases we see from northeast area, and they are, low to mid socioeconomic status, and most of them we see for the gallbladder, some gallstones and all they operate, and they come up with the histopathology came as adenocarcinoma. So that is what we commonly see in our HCG actually.
Yeah, that incident in the post-op we are finding histopathology malignancy. It was operated as a gallstone as a laparoscopic cholecystectomy, but they'll come a second opinion like restaging research. That's one of the common this one. Dr. Guru, what is your how is your case?
Caseload
Like
is less. Caseload is less, 1 to 2 cases. Type of cases, intrahepatic cholangiocarcinoma is the one which is the confusion one, where we have difficulty in diagnosing between HCC versus intrahepatic cholangio. Lot of diagnostic dilemmas things. Socioeconomic status here is poor. Performance status is not is good most of the time if it is intrahepatic cholangio. If it is gallbladder, it will be extensive ascites and it's a bad performance status. Resectable versus advanced, most of them are advanced cases.
Okay, okay. Dr. Rakshit, sir, surgical, because you are the one surgeon, is there like because we treat most of the time in advance, sometimes in adjuvant or neoadjuvant. How would do you see OPD coming to you? Like one of the Dr. Srinivas has told scenario post-op incidental, that is a gallstone tumor. That is one of the scenario might come. But how you see that operable gallbladder tumor or a biliary tract tumor in your practice? Rakshit, are you there?
Ratish, I think he has not joined. I
Is
think.
not. Yeah, okay, fine. That I think is a, I think more of our understanding is hardly will see operable. Most likely
Yes.
we might find the incidental the post of finding you might come. Dr. Mekla, do you have any opportunity to give a adjuvant radiation? Any like this? Do you see that early stage operable case in your practice?
No, sir. Honestly, I have not seen even I have not treated a single case of gallbladder malignancy.
Okay.
I've only heard our medical oncologist or surgical oncologist present in the tumor board, and some historical reports of our seniors having experience with intraluminal brachytherapy. So, but personally, I have not. Of course, we don't have SBRT in our center, but we've not used any conventional form of radiation for any adjuvant or any other form of treatment of gallbladder cancer.
Yeah, I'll come with like a role of radiation. Your role sometimes medical unfit for this one for a surgery, or maybe sometimes you come in. That is the role is there. SBRD some like you can try to go. Let me come later. I'll come back to you. See, that's I think you have seen except surgeon like everybody is there if you see that how is your practice, usually it'll come directly to you or refer to you, and do you have any you decide treatment alone or you want to have a ability and decide? That's what I want to hear. Abhilash,
Sir, most
you
of the
directly.
patients they do come present with, as we see, advanced disease. So most of them will be diagnosed with icterus. So they will be doing some of the imaging, and they'll find intrahepatic disease or hilar cholangiocarcinomas. So they usually come to surgeon first, sir. Then we'll have a detailed staging investigations. So if it is not operable and they think it's advanced, we discuss in the tumor board and we take them for systemic treatment.
Okay, okay. Do you think if at all you want to see that you have a policy okay, MDT is there, which are who are the people you want to involve because it has come to you directly. Who are the people which are the specialists you want to involve in your MDT?
So we usually involve all the surgical oncologists, we medical oncologists, and also the radiation oncologists. Sometimes the interventional radiologists also for the stenting procedures, all those things we take opinions.
Okay, okay. Any other you want to include or just okay? Okay, Srinivas, yeah, MDT. You want involve any other other than Abhilash has said? Srinivas, BJ Srinivas.
Yeah, hello. Pathologist and radiation oncologist. Yeah, I think
radiation is
genomics, genomics, molecular biology people I want.
Molecular. Okay, then you want to include even okay, hepatobiliary hepatologist you want to include. Okay, Dr. Srinivas, why you want to include hepatologist actually?
Because I mean, hepatologist or any surgical oncologist. I mean, not particularly hepatologist.
Yeah,
Any surgical
surgical
oncologist.
oncologist will be there. Guru. Yeah, they are also important person, but we may not include, but we should be there. Their role also is there. Yeah, gastroenterologist, medical gastroenterologist or hepatologist will be there.
Yeah, surgical gastroenterologist, interventional radiologist for ERCP or MRCP, pathologists for biopsies, surgical oncologists because they are our friends, we can't go bypass them, medical oncologists also. Radiation oncologists, we rarely ask them because most of the time they'll say no. And that ends this one. I work in a city where there's no hepatologist and who will do liver transplant. So I have only a place where a surgical oncologist works, or a
Yeah,
surgical gastroenterologist who doesn't do liver transplant.
yeah, like see, sometimes a transplant surgeon, liver transplant surgeon hardly will get it, but that if there is well and good, surgical, medical, and radiation oncologist, our oncologist group profile will be there. Pathologist also, that is definitely be required because there's a confusion of intrahepatic or HCC, that discussion will come actually. IHC, that is a diagnostic issue will be there. And the radiologist definitely intervention radiologist, even both for a diagnostic biopsy purpose and even for the interventional like a PTVD. If you are going for a central intrahepatic obstructive jaundice, anything is there, we will try to do. They where the role of the medical gastroenterologist will come, or even hepatologist, medical that non-transplant hepatologist, like they try to have a even associated hepatitis B or FCB positive or altered LFT. Definitely their help is required. Most of the time we'll try to label them child cook B or like see something that like we try to do titration as per like medical oncologist we try to do, but definitely if their role is there is well supportive for us. And if it's a DRC fee required and stunting, all the thing, definitely the medical gastroenterologists are their role is there. That is like not like all the abdominal tumor. That some like okay, that is if you try to go for the peripheral biliary tract tumor, obstructive jaundice, there's stunting periapillary tumor. We try to involve them, and definitely that social worker and molecular genomics team and the even our counselor definitely onco nurse is definitely helpful for us because we are like helping for them. Like sometimes they require a line, chemo code, peak line, all those helping for them counseling will be definitely like required. I think this we already discussed hepatologist. I'm not going for that. And they try to have altered liver function and even if by infective viral this hepatitis C, they're definitely they're helpful for the including the like helping for management for along with the like our current medical management. And question to the that guru, like, do you have a other than IHC sometimes intrahepatic and HCC confusion IHC will do? Do you perform other than that IHC that okay that you know the site for either gallbladder or intrahepatic or maybe straight away is a biliary tract tumor? It is IHC has come. Do you conduct any molecular test routinely in your biliary tract tumor? Guru?
Affordability becomes a question. Most of them are. I
Yeah,
don't
forget
do
about
so. The
no,
answer
forget
that
about today. Like
yeah.
you are there sitting in a big hospital and the affordable patient. No, no, that's I'm asking. But yeah, practically
Yeah,
we are
if
not doing for that issue. But you want to do it.
yeah, will definitely want to know because the treatment is hugely different intrahepatic cholangio versus HCC. Definitely want to do. If they're not affordable, we'll do it, sir.
Okay. And Srinivas, Abhilash.
Yeah. So for patients with gallbladder tumor, usually I order for this PDL1 and HER2/neu.
Okay.
And I mean, molecular testing, NGS, yes, it is possible because one IDH mutation is there. There are recommendations. So though it is not available in India, but I think NGS is there. It is I usually order. Otherwise, HER2/neu is commonly we order for most of the patients.
Yeah, yeah. That important at least basic thing MSI, HER2 and PDL1. These are the three things here. Try to basic thing IHC you can get it done in any center. And NGS definitely newly diagnosed. Yeah, I try to give a value that is debate is whether to do first line, second line, all those things that if we do that is well and good, even if is there like even the issue about the all about the molecules, all those things. Definitely there is one of the molecular physician medicine other than lung and FWRE we are conduct NGS because it is optional like because the issues like a practical issue about the cost factor all this will come but that's like to do it. Okay, this I think this is a genetic alteration biomarker testing. You can see that a lot of changes are there. You can HER2 is a one thing, even R3 also is a combination. HER2 and R3 also can have that like you can have the difference. KRAS mutation will come common in the extrahepatic, and this difference is there. Difference of we'll try to understand ARIDA alteration that is there, and then MET amplification, and you can try to have GR like pathways are there because we have a molecule for that. PIK3 also is there. KRAS, even though the drugs, the allability issue, that success story is not good. IDH inhibitor also is there. It's a busy slide. You are having so many genetic changes. It's one of the malignancy. You can show some genetic alteration. You can see here. If you do that other than routine treatment, it try to add stuff actually to the treatment. As a newly diagnosed, I think the three important thing is I said about the HER2 and MSA and a PDL-FSA, that is also an added factor. Later, it try to require for a second line, all those things. As ESMO guidelines, that practical a BTC classified as per the that ICD that criteria. You can see the biopsy definitely require tissue IHC, and you should definitely try to upset to that definitely that you try to relief of the obstructive jaundice with either a PTBD stunting or the ERCP. All those things you try to do it. And once you have a molecular test, is it is a recommended. It is for a systemic treatment is 1 year recommendation. Molecular analysis is supposed to do it. Elevated CA 19-9. It is one of the poorest prognosis. If it there arises, the prognosis not good. So it is just see that it's a multidisciplinary team is required, but only thing we try to see that advanced disease and early disease incidental. If you have a gallbladder tumor, it is a gallbladder it's removed in the just incidentally because of a gallstone, you might accidentally, you can see surprisingly, you see the histopathology. Try to even the gallstone surgery, tell them that at least histopath report also that you have to see. Sometimes some of the institution older, they try to remove the thing, the laparoscopic cholesterol, but never is to see the histopath report. That you should cross check actually. That is most important. You find that there's one of the thing you try to pick up, but definitely presentation and diagnose early definitely is very rarely will find out early stage disease. Most likely either local advanced or advanced disease is there. I think we try to surgeon is not there. I think because of the vast experience with the all expert panelists here, surgery if it's it is rarely found that incidental you go completion surgery in that case. Otherwise, local advanced I think medical colleagues are there. Do you want to conduct a neoadjuvant treatment in the local advance, either intrahepatic or any extrahepatic cholangiocarcinoma gallbladder tumor? Abhilash, Guru.
Sir, when we find it, incidental finding is there. If it is T1B and above, we do staging, and the surgeon thinks if it is resectable, sir, sometimes I think we go ahead and give neoadjuvant chemotherapy, and there we can have some benefit. That's what I feel, sir.
Okay. Their role is that is they require intrahepatic cholangio. They're that let us come next there is surgery completion early if you have to do it. Adjuvant also I'll come later. There's a broadly if it's metastatic, you will have a molecular profiling also important that in this disease you should do it. Generally, yeah, no jump cisplatin based will try to go, and later molecular based treatment will try to go. This is surgery resectable will try to go in this way, and unresectable majority will, it is our practice. Either you'll try to go for the basic treatment. I think surgeon is not there here. I think you are heard of a surgery as a just called radical cholecystectomy, or a surgery for a biliary cholangiocarcinoma, or any role of transplant. Any one of you, because we have a running short of time. Role of transplant in the intrahepatic cholangiocarcinoma, localized disease, locally advanced disease. Surgery is also quite sufficient, but even unresectable early intrahepatic cholangiocarcinoma, peripheral cholangiocarcinoma, still that is a transplant scores better than the resection. But it is in the node negative disease, you try to have that node positive, that I don't think much, node negative, the transplant scores better, but you should consider, but you should involve them. But availability, that facility, all those things more important. And adjuvant treatment, I think what is the practice Abhilash? What are the regimen you try to practice? Surgery a post which are the cases you try to go? Gallbladder and biliary tract, all the cases will give, they are very aggressive disease, they'll come back.
Yes, sir. surgical resected case adjuvant, we are offering all of them systemic.
Yeah, what is the regimen you will use it? Adjuvant treatment.
I was using gemcitabine and capecitabine, sir. Recently, single agent capecitabine also we are using for 6
Okay,
months.
Guru, what is your practice? Adjuvant
Gemcis,
treatment. Gemcis, okay.
Gemcis.
Gemcis is fit enough to take for a cisplatin, otherwise maybe alternative, gem based, like maybe capecitabine or oxaliplatin, something you try to. What is Srinivas? Anything difference from you?
No, same. I agree. Gemcitabine, capecitabine, or gem cassis or carboplatin.
Okay. There's a the resectable like borderline is there. They try to go for neoadjuvant treatment. What is the neoadjuvant regimen you try to practice? Srinivas?
Neoadjuvant once again gemcitabine, cisplatin.
Cisplatin. Do anyone? I think any colleague like you have anything different regimen?
Sir, we can use K-Fox or Polfox also something.
Polfox. Okay. Guru?
Gemcis or Gemcap? Gemcap also is a good option.
Okay. Anyone
Gemcitabine with
practice?
capecitabine.
Triplet regimen, anyone practice?
Nab-paclitaxel we have tried, but we burn our fingers. So
Yeah, like the most majority doublet, like that is fit enough, like that young fit, you can have triplet regimen. Response is very good, and PFS benefit is there, but toxicity, added toxicity, but we cannot apply. But majority we are having finding it difficult to use doublet, gem cisplatin. We may go gem oxaliplatin or maybe gem capecitabine. These are things, lot of modifications we'll try to do. But like definitely in neoadjuvant, they try to tell local advance, they try to increase the response rate and even resection rate also in intrahepatic cholangiocarcinoma and gallbladder tumor, local advanced disease. Definitely those who underwent surgery, definitely the survival is better compared to those who are not undergone. That's what like you should have that is a multidisciplinary is important. Surgeon, all the things. This is one of the data from our Indian data. Any role of local regional therapy? I think I like other than this, Doctor, I want to hear from Mekla. Anything like, see, surgeon is like local advance is a medical oncologist given a new urgent, but finally he'll tell I can't operate. Do you want to any local regional therapy you want to do? Other than any this like your radiation oncology, any other local regional therapy you want to add? I think intrahepatic you can conduct something local regional therapies.
Local regional, there are, I mean, we can definitely, one is adjuvant, and the definitive in unresectable gallbladder and intrahepatic, definitive chemoradiation itself can be given. So that could be either by IMRT or we can use stereotactic treatments.
Okay. Yeah, intrahepatic
Dr.
cholangio.
Satish,
Yes.
I will request you please conclude your
Yes.
talk for the next one.
Yes, this is like what are the preferred, like I think I already we have discussed triplet regimen also. It is, scores better actually that gem cisplatin like the standard practice and even oxaliplatin also they try to replace this. One of the studies there. They're having almost a safety that all of it is better. Sometimes we are like a borderline renal function. You can interchange. This is one of the things. It's published from AIMS also. You can have that. You can interchange. You can see that this is a triplet regimen. Definitely is good response, durable response, but you should see the selector patient. Like uses the phase 2 data, and there's a phase 3 data is there. Like because what are the thing different you want to do? Because lack of time, like I think advanced this is anything you want to do different. This is the standard practice. Role of immunotherapy, first line. Abhilash, like Guru Srinivas. Do you have other than this only the practice chemotherapy and you want to combine immunotherapy in the first line, second line? What is your practice?
Sir, now upfront any newly diagnosed case as per this TOPA study. So the guidelines are like with durvalumab, gemcitabine, and cisplatin, followed by durvalumab maintenance.
For this, you require molecular marker or irrespective molecular marker you will do?
Irrespective of PDL1, we
Srinivas and Guru.
I think I will also practice upfront immunotherapy, respective of molecule.
Two drugs are there right now. One is durvalumab and pembro. They are the two approved drugs right now. And durvalumab was the oldest one. Pembro is the newer one. And can be molecular selected, cannot be molecular selected. Roughly around 35 days to 50 days PFS and 35 to 50 days OS also benefit. So decent benefit, cost effective. Let's see over time how it works. There are two drugs are there.
Yeah, still we are doing molecular marker, but even negative also we'll try to add a durvalumab. That is the data is there. Is like you can see that because of lack of time, like I'm not able to show. Like here, like overall, it is show that like you can see initially you may not see that much difference. You can see like a 18 months, 2 year. You can see that doubling that overall survival rate benefit, and even the PFS benefit also is there. Irrespective subgroup is not like intrahepatic, extrahepatic, gallbladder, all the thing, all subgroup like is try to go, and even also pedal expression also irrespective whether is a pedal or negative or like positive or unknown also. Like
Ideally, a patient without hyperbilirubinemia, ideally, should not have jaundice. These
yes,
IUs.
yes, yeah. Iris like yeah, that we have to see that like because in the trial all those there are excluded, and 2 year surrel rate definitely is achieved with this almost like it is one of the thing it is impression is crossed at more than 2 years. This the data is there like you can see here PFS benefit as various interval 6 month like a 12 month, and is behind that PFS is maintained like that's what it is more important. And is benefited in all the subgroup of people, and look at the response rate even like even by adding this like not only like you can see that IO drug definitely you can see various malignancy. You see it's a dramatic response like here like the response definitely is going to be increase in the rate compared to the only chemotherapy, but is a translate into even the meaningful like PFS and overall survival. That's what we try to see. What you thought of about this PFS and overall response? Overall response is improvement is there, PFS is also is there. Safety tolerability, I do have experience with IO, this Trulumab, Srinivas and Abhilash, Guru. Have you used?
Yes, I have used. I mean, safety. I mean, there is no special whatever other immunotherapy. Same. I think very well tolerated. I didn't come across any significant side effect with this actually.
Guru, anything?
Same thing.
Yeah.
It's safe, pretty safe.
I think you're pretty like safe, like you're already well versed with using other IO drug, Duo and Pepro, and I don't think you feel like anything like adding this to the chemotherapy. We don't feel like anything any added toxicity. You are able to manage. Abhilash?
Yes, sir.
I
Yes, sir.
think
Yes,
that
sir.
yeah. I think that there are like some there are minor immuno-oncology related adverse events, some skin rash and hypothyroid endocrine, some like added GI toxicity. I don't think anything. There are those are having immune related toxicity. Definitely, they try to have they have a long term disease control. Also, that the data is there. See which are the following. You try to see that PFS data is beneficial and overall response and durable response is better. Toxicity is not added, like it's a marginal increment, and the overall survival rate also is to try to have that. Which are the things like use like which is impressing to use this regimen? Top S1.
All of the above. So PFS is good, overall response is good.
Yes.
So it's a good drug. We should try, and it is something after 10 years we're getting a good drug.
Yes, yes. Anything, Srinivas?
Yeah, I agree. I think most probably we.
Yes, yes. Do you think it is a practice because it's going to benefit not only one, right? Irrespective to the molecular tumor marker, like that is a PD-L1, we not like that. So it's going to benefit in all the subgroup. It is a broad spectrum, like it is definitely is a practice changing. Like it's not like added toxicity. Only when the finance is the one thing in our clinical scenario, but otherwise, I think it is considerable like in all the cases. Like it is a potentially changing like our practice day to day, and definitely that almost like near 13 years we didn't add any only chemotherapy options. The triple therapy was tried and implemented, but added toxicity, but survival advantage was not there actually. But this is one of the thing is going to show that safety, tolerability, and the meaningful improvement in all the aspect of response rate, all the thing. Thank you. I'll stop here. Like anything, any questions like I can discuss. Thanks for all the panelists making that a wonderful discussion. Srinivas, anything you have a question and
I think in the interest of time, I think we'll push to the next session, sir, because we
thank
are
you.
late. Thanks for that wonderful moderation, sir. As always, you're a wonderful speaker. Thanks for joining us.
Thank you, Srinivas.
Thanks all the panelists.
Thanks
all the panelists for a wonderful interactive session. With that, we'll come to the end of that session and we'll move on to the next session. An update on Himalaya trial. Dr. Sai Vivek is going to present the data on that. Over to you, Dr. Sai.
Thank you, sir, and thank you for the opportunity. I'll be just sharing my screen now. Yeah. So I hope my screen is visible and I'm clearly audible.
Yeah.
Yeah. So I think just a small background on the update on the Himalaya trial that we'll be speaking about today. And just as we are moving around from BTC, so since till atezolizumab and bevacizumab came into the picture in the IMBRAVE 150 trial, we just had sorafenib or lenvatinib, which was non-inferior to sorafenib, which was available for us to treat our unresectable hepatocellular carcinomas, where we didn't have any role of local therapy also. So from there, we have another option because of the Himalaya trial, where we have a combination of tremelimumab and durvalumab, and which becomes the STRIDE regimen. So the STRIDE regimen stands for single tremelimumab, regular interval durvalumab. So that is one dose of tremelimumab with 4 weekly of durvalumab, 1,500 of durvalumab and 300 milligrams, one dose of tremelimumab. So now we know that one is a CTLA4 inhibitor, that is tremelimumab, and durvalumab is a PDL1 inhibitor, and a combination of both was tried in this particular trial. And the final analysis was recently presented at ASCO GI 2022, and let's go through that briefly. So it was a phase 3 randomized open label multi-center study, and the one arm was closed. So the 3 arms which were analyzed were tremelimumab plus durvalumab alone, and sorafenib. So good number of patients. And one thing to note here is the study population. We all know with the atezo-bev study, we know that the people who really benefited are the people with viral etiology for cirrhosis and HCC. Here again, there were patients who were confirmed unresectable hepatocellular carcinoma, BCLB-B not eligible for therapy, and BCLCC, Child-Pug A alone. So that's one more point. So we tend to use them for Child-Pug B, and then look at the responses and hope that they would be as good as Child-Pug A, but no. So they took only people with Child-Pug A and no main portal vein thrombosis. And one more thing was Napo-GI endoscopy was not required because it was a dual IO trial. So it was Tremi-Durva versus durvalumab versus sorafenib, and the stratification was macrovascular invasion, etiology of liver disease, and performance status of 0 to 1. The primary objective here was overall survival for the combination regimen. Secondary was OS for durvalumab versus sorafenib, and additional objectives of PFS, overall response, duration of response. So as we see here in the patient disposition, the patients were most of the patients at the latest follow-up had discontinued the study, but numerically, the number of patients who were on study was higher in the combination of durva plus tremelimumab arm. So they were well balanced. What we see here is hepatitis B, HCV, and non-viral etiology are equally balanced. Most of the patients were BCLC-C, and 99% of them were Child-Pug A because that was the inclusion criteria. And PDL1 and AFP were also looked into, but again, well balanced. So the update that was presented in GI 2022 included what the patients received as a subsequent therapy. So almost all group of patients did go on. Around 40%, 50% of them did not receive, and around 40% of them went on to receive a subsequent therapy. So one point here to note is, as we are clearly seeing even here, only around 50% of HCC patients really go on for a second line therapy. So it's always best to consider the best option we have in the frontline setting and not wait for progression to decide on IO or whatever is the standard of care as of today. And majority of them receive targeted therapy. So this is the primary objective. This was a 36 months overall survival analysis for the combination versus sorafenib. As we can see here, there is a slow but definite separation of the curves, which are flattening as we go past 2 years. So the 36-month overall survival rate was 30 versus 20%. And we have an update here, which is a 4-year overall survival data, which is 15% versus 25.2%. So at 4 years, we have almost 1 in 4 patients who are doing well and going on with the combination regimen of STRIDE compared to sorafenib. So there is a numerically and statistically significant benefit in terms of overall survival with the STRIDE regimen. The hazard ratio was 0.78, showing us a 22% decrease in the hazard for death, and the median overall survival was 16 versus 13.8 months. The secondary objective for overall survival versus durvalumab, single agent durvalumab versus sorafenib, not statistically significant. The confidence interval goes beyond 1, and the median OS was 13 versus 16 months here. As we again see in the Kaplan-Meier curves, there is no real separation, and again, as we go along with time, there is almost a crossing over. So we could say statistically this was a negative thing, single agent durva versus sorafenib, and this is the 4-year update of the thing. Though there is a numerical advantage, statistically it is not significant. Even at 4 years, it's 15 versus 19.1%. Now coming to the forest plot and seeing the subgroup analysis here, as we see one thing here at the I'm Brave, we saw that non-viral really did not do well. But here, if we see, this is a small number of patients, I agree, but HBV and non-viral did well compared to the HCV. And patients who the performance stage BCLB B or C doesn't matter, but most of the patients have BCLB, BCLC C. And PDL1 was one of the factors that they explode, but it really did not have a significance. And one more thing to note is they explode also the AFP levels at enrollment into the trial, and patients with AFP levels of more than 400 seem to derive a greater benefit with the combination of CTLA4 plus PDL1 inhibitor. Now, the 4-year OS by etiology, STRIDE versus sorafenib, as we see here, with HCV not numerically lesser, but definitely it is to the left of the mark, but the confidence intervals kind of goes beyond 1. But for HBV and non-viral, definitely there is benefit as per the trial. And the response rates, we know we're dealing with dual IO. So the response rates were around 20%, higher than definitely sorafenib versus durvalumab, with 3% of them having a CR. And the median duration of response was higher definitely in the IO plus IO arm, and the patients who responded remaining in response was almost 80%. So we know a subset of patients, but with the 4-year data, we know 1 in 4 respond to this regimen, and after 4 years also they're alive. And once they respond, what we see here is once they respond post 6 months or even post 12 months, almost 2/3 or more than 50% of the patients do tend to remain in response. So the safety and tolerability. So let's compare the dual IO with sorafenib. We know sorafenib is not an easy drug to use, that we all have to dose reduce at some point, and at the full dose, it's not tolerable. So if I'm comparing a grade 3, grade 4 toxicity directly with sorafenib, they're almost equivalent, at least even more in the sorafenib arm. Now we know how to manage IO plus IO. So serious adverse events, definitely there were some more adverse events in the IO plus IO arm, and some of them, around 2% of the patients had an adverse event related to death, which was mainly because of an ARDS, hepatitis, myocarditis, pneumonitis, and one patient had a myasthenia gravis, and one patient had a heart failure. So some patients did experience slightly higher adverse events leading to death in the IO plus IO arm, but we all know that we are getting better at detecting them early in grade 1, grade 2, and managing them well to avoid the patients having a grade 3 or grade 4 toxicity. So the treatment-related hepatic or hemorrhage events, as we can see here, hepatitis is one thing which definitely is higher, especially the aspartate aminotransferase, definitely numerically higher. But if you compare it to the sorafenib arm, they are almost similar. So there are no great red flags here when we're talking about IO plus IO regimen. The immune-mediated responses leading to discontinuation, again, here, as we can see in the two, the right hand and left hand, they're almost comparable to the single agent durvalumab. not sorafenib, single agent durvalumab, almost the hepatic events, which were the ones which were more commonly seen, are comparable at 2.3% versus 1.3%. To summarize the Himalaya study, it was a large phase 3 study that included a global and heterogeneous population with unresectable HCC, a single priming dose of tremelimumab plus regular interval, that is once a month, durvalumab regimen statistically improved overall survival versus sorafenib. So at that point, sorafenib was the standard of care. So it was almost 15 versus 25%. So that is a good number to have at 4 years, especially with HCC, where we really didn't have much of choice. And AFP more than 400 in the subgroup analysis did really well, along with HBV and our non-viral etiology. So the long-term OS benefit with STRIDE versus sorafenib was not driven by any particular subgroup of patients. The STRIDE regimen maintained a tolerable and differentiated safety profile from other current unresectable HCC therapies. So these reinforce the sustained and long-term OS benefit of the STRIDE regimen. And a 4-year data is always good to have, especially in HCC. And that would complete our talk for today. Thank you.
Thank you, Sai Vivek. That was a wonderful presentation on Himalaya update. We, in just interest of time, we'll quickly move
from the standard investigation for all non-small cell lung cancers, particularly adenocarcinomas. And this is going to be the overview of my talk. We talk about survival patterns for the current use of TKIs and how we can improve them using combinations such as TKI with chemotherapy, TKI with VEGF inhibitors, as well as EGFR antibodies. So we know that EGF NSCS non-small cell lung cancer has now evolved from histological to molecular subtyping. And we use both single gene sequencing as well as single gene testing as well as next generation sequencing. The common single gene testing that we do on a clinic are EGFR, ALK, and occasionally ROS. However, next generation sequencing encompass a wide variety of genes. And depending upon the results, we look at what targeted therapy to give. And if no target is identified, then possibly look at some chemotherapy. So the biomarker testing that is recommended currently is EGFR, ALK, ROS, and PD-L1, either simultaneously using single gene testing or as on the NGS platform. And if you're doing single gene testing and the driver is not detected, then a multiple gene panel is then subsequently requested as reflex. The question is, what happens when they do progress on first-line treatment? Depending upon the treatment they've had, we can either consider a repeat biopsy and a second-line treatment, depending upon the biopsy report, or chemotherapy. And the biopsies can be in the form of either tissue biopsy or a liquid biopsy. Because of all of these, the persistent NGS testing and the role of targeted therapy such as TKIs, I think non-small cell lung cancer has now transformed over the past decade or so. And prior to that, I think a median progression-free survival was about 4 months with a platinum doublet with an overall survival of 8 months. And now we are looking at a progression-free survival of about 18 to 24 months and a median overall survival that is exceeding 3 years. So we've come leaps and bounds, but still got a long way to go. So how do we go that distance? How do we improve outcomes? We can do that by combining drugs. So we know that EGFR TKIs from the mainstream. And the question is, can we combine them with either a cytotoxic chemotherapy or a VEGF inhibitor or another EGFR antibody which acts on the extracellular domain? And all of these are reasonable things. And we'll look at some of the data's around that. So we know that there's good rationale for combinations, both with TKI as well as chemotherapy, because they act in a different manner. One is a cytotoxic, the other one being a target inhibition. So this was the TATA study, which looked at combining geftinib with chemotherapy. It was a randomized phase 3 trial in newly diagnosed metastatic non-small cell lung cancer who were found to be EGFR mutated. Patients were randomized into 2 groups, one receiving geftinib with chemotherapy and the other one geftinib alone. And the patients were stratified based on their EGFR mutation, that is 19 versus 18 or 20, and ECOG performance status. And the primary endpoint was progression-free survival with various endpoints, secondary endpoints, including overall survival. And this was a hugely positive study. When we look at both the progression-free survival and overall survival, both were in favor of those patients receiving the combination of gefitinib and chemotherapy. So in progression-free survival, the hazard ratio was 0.51, and in overall survival, the hazard ratio was 0.45. So both of them highly statistically significant. So I think based on this study, most of us have felt that giving gefitinib with chemotherapy is a very, very reasonable option, certainly more reasonable than giving gefitinib single agent alone. So when you look at the subgroup analysis, I think across all subgroups, the benefit was there for the combination as opposed to single agent. This was the NEJ009 Japanese study looking at a similar patient population and a randomization and looking at a combination of gefitinib or chemotherapy, which is pemetrexed and carboplatin, versus gefitinib alone. Of course, the maintenance continued with pemetrexed and gefitinib as in the Tata study. Primary endpoint was progression-free survival, and the secondary endpoint was overall response rate, safety, and quality of life. And in this study showed that in the progression-free survival, it was statistically significantly beneficial for the combination arm, which is gefitinib and chemotherapy versus gefitinib alone. The hazard ratio was 0.77. That was the PFS2, sorry, the PFS1, the hazard ratio was 0.58, and the overall survival, even though it was a trend towards better outcomes, it was not statistically significant. When we look at the various subgroups, I think the benefit was there across the vast majority of them. However, some of them were crossing the line of unity. When we look at other studies combining TKI with chemotherapy, there are various other studies which show a similar pattern where the progression-free survival was significantly better, but the overall survival was either not reached or not statistically significant. So now back the question is, can we look at newer TKIs such as third generation TKIs, osimertinib in combination with chemotherapy, and so forth. This was a very nice study called the AGAIN study, which was a phase 3 sequential study. So that this particular study sequenced TKI with chemotherapy. So basically the study initially started with using gefitinib, but then subsequently based on the FLORA data moved to osimertinib. So in this study, the study team looked at a newly diagnosed metastatic non-small cell lung cancer with EGFR mutation without any prior systemic therapy. They received 2 months of either gefitinib or osimertinib, followed by 3 cycles of chemotherapy with cisplatin and pemetrexed, and then subsequently reinitiation of gefitinib and osimertinib till progression. So when you look at the primary endpoint, so the primary endpoint of the study was overall survival. There was absolutely no difference in either of them, whether we looked at gefitinib with chemotherapy versus gefitinib or osimertinib with chemotherapy versus osimertinib. It was not statistically significant in terms of overall survival. However, when we look at the progression-free survival, the benefit was certainly seen with gefitinib combination, but not with osimertinib combination. This was another study, which is a phase 2 study evaluating whether osimertinib in combination with chemotherapy would be a reasonable option for a similar group of patients. So in this particular study, which was a phase 2 study, they looked at 66 patients and gave them osimertinib along with pemetrexed and either cisplatin or carboplatin with maintenance pemetrexed and osimertinib. And basically, the 24 months PFS was about 70% in both of them, and 24 months overall survival was 92%. So there certainly was activity to be seen in this particular combination. So based on this data, the FLORA-2 study, which was recently reported in the World Lung Cancer Congress, reported a positive outcome. So in this particular study, they looked at a combination of osimertinib with chemotherapy. So this had taken patients who were treatment naive, first-line treatment, who were EGFR mutated, non-small cell lung cancer, pathologically confirmed. Stable CNS metastasis was allowed, and brain scans had to be done at baseline. Patients were stratified based on the race, EGFR mutation status, and performance status. When we look at EGFR mutation status, they looked at local versus central testing. The two group of patients, one group of patients had osimertinib along with pemetrexed and platinum every 3 weeks for 4 cycles, versus and then subsequently had maintenance osimertinib and pemetrexed till progression, and the standard arm was osimertinib single agent till progression. The primary endpoint was progression-free survival, and there were various secondary endpoints, including overall survival. And when we look at the progression-free survival as per investigator, It was statistically significantly in favor of the combination arm, which is osimertinib and platinum pemetrexed, which was 25 months. So PFS, now we're looking at reaching 25 months as opposed to 16 months with osimertinib monotherapy, which is in keeping with what we had seen with the FLORA trial as well. When we look at the hazard ratio, it is 0.62, statistically significant in favor of the combination arm. Similar data, when we looked at the blinded independent committee review, we saw 29 months versus 19 months or 20 months. A similar benefit was seen at the hazard ratio of 0.62. When we look at the subgroup analysis, I think it was pretty clear across all subgroups. The benefit was there for the combination arm as opposed to the monotherapy arm. Particularly when we look at the EGFR mutation status, it made no difference. And when we look at the CNS CT cells baseline, the benefit was higher in those patients who did have baseline brain mets as opposed to those who didn't, but in both of them there was benefit to be seen. So this is essentially the brain mets of patients who had brain mets at presentation had a hazard ratio of 0.47, and those who didn't had a hazard ratio of 0.75. But I don't think so there's much to read between either of the two. I think the benefit was seen across both of the groups. Similarly, we see with the type of mutation. When we look at the toxicity, I think there was a higher grade 3 toxicity because in the combination arm, purely because of the myelosuppression that we see with chemotherapy, but nothing that would be unexpected or untoward. Looking at other combinations, TKI versus VEGF inhibitors, various studies have been done looking at the combination of TKI plus VEGF inhibitors. The largest phase 3 studies were the NEJ026, the CTONG study, and the Relay study. Relay study looked at ramucirumab, and the other two studies looked at bevacizumab. And when we look at the summary of all of the 3 large phase 3 studies, I think the PFS benefit was certainly there in the combination arm, but not so much with the overall survival. So I think if someone wanted a chemo-free regime, I think TKI in combination with the VEGF inhibitors would not be unreasonable. But please remember that the TKI used in this was erlotinib and not osimertinib. When we look at TKI plus EGFR antibody, I think this space is getting quite interesting now with companies evaluating the role of lazertinib, which is a highly selective brain-penetrating third-generation TKIs, and its combination with amivantamab, which we know that is currently licensed for uncommon EGFR mutations. So when you look at a very early study of 45 patients who had progressed on osimertinib, who had EGFR mutation, there was an overall response rates for about 36%. In the Chrysalis trial. These are those patients who had progressed on osimertinib. When we look at the Chrysalis 2, which was the expansion phase 1 study, the combination of amivantamab and lazertinib were reasonably safe and accepted. And this particular Chrysalis 2 had 4 cohorts, and I think they were looking at reporting the cohort A, where you had post osimertinib and in combination with platinum-based chemotherapy. So this study, I think the other cohorts are yet to be reported, but the brief is that the amivantamab and lazertinib do yield some anti-tumor activity, where the combination is better, particularly on those patients who are progressed on osimertinib and platinum-based chemotherapy. And there were no new safety signals. So currently there are a couple of ongoing phase 3 trials. The Mariposa 1 and the Mariposa 2 are trials assessing. So Mariposa is currently assessing lazertinib in combination with amivantamab as first-line therapy, and then Mariposa 2 is looking at amivantamab and lazertinib in combination with chemotherapy and pemetrexed following progression on osimertinib. So currently, the space following progression of osimertinib is a bit sketchy. Apart from chemotherapy, we don't really have much more to add. We could look at ABCP regime, which is ati-bev, but still. It is not robust. So this particular study is looking at addressing the question, what happens on osimertinib failure? And so we are hoping that the Mariposa and the Mariposa 2 would be read out in ESMO in a few weeks' time. So to summarize, newer TKIs plus chemotherapy do offer a new first-line treatment options, particularly when we're looking at a combination of osimertinib along with chemotherapy. I think the data was just read out in World Lung Cancer Congress. I think we have to look at approvals and how we can incorporate that in our practice. But the data certainly is interesting in terms of significant PFS benefit for those patients exceeding 2 years. TKIs in combination with other therapies such as VEGF inhibitors and EGFR monoclonal antibodies do look promising. We do need to wait for the Mariposa studies to be reported later on this month. More importantly, I think patient selection is going to be vital with so many choices currently being there. That is it really from me. Thank you very much.
Thanks, Dr. Vijay. I have a question.
Yes, sir.
So where are you going to fit FLORA2 regime in your practice?
So currently, I think we, of course, don't have any discussions. And one of the reasons for coming to these meetings is to discuss where we actually fit the FLORA2. The current trial is looked at chemotherapy naive patients. So it would be first-line treatment. So whenever we're thinking of giving osimertinib, we should consider giving osimertinib in combination with chemotherapy. But I think patient selection is going to be key. We're looking at improving PFS from about 16, 17 months to about 2 years now. So as long as you have the right patient selection, I think the first-line treatment could quite reasonably be a combination of osimertinib with platinums and pemetrexed, with pemetrexed and osimertinib going on for maintenance.
Going to be a norm, that's going to be a routine practice in future.
It should. I think following a few meeting discussions, and I think if people are in agreement, and of course we get some own first-hand experiences, and I think going forward that is likely to become the standard first-line treatment.
We are familiar with PEM-carbo regime. We are familiar with osimertinib. I think the combination should not have any problem because they are all very familiar for us. We are practicing it for quite some time. And we know the toxicity.
I think we all have experience with geftinib and chemo combination, and we really don't struggle with that. And osimertinib is a lot safer than geftinib is. So I really don't see much problem with the combination in terms of toxicity. Certainly, the trial data probably just showed a higher myelosuppression, which is expected from chemotherapy, but nothing much more untoward.
Young patients, EGFR mutated, I think this is going to be a norm later in future, probably. Yeah, of course.
I think the immediate future, really.
Immediate future, yeah, I agree. Thanks for that wonderful presentation. Then
sure.
The next session sponsored by Glenmark, role of neuroantiemetics in oncology by my very good friend, Dr. Ravi Tippaswamy. Over to you, Dr. Ravi.
Yeah. Thanks, Dr. Srinivas, and it's lovely to see the wonderful scientific event. I will start my sharing the session. I hope my screen is visible.
No, sir.
No?
Yes, sir, it's visible.
Yeah, thank you. So in the next 15-20 minutes or so, we'll briefly discuss a very common topic which we were all earlier. It was very difficult to manage, but now I think with the present antiemetics, it's very easy. And nowadays, I think we hardly face this problem. So chemotherapy-induced nausea and vomiting. When we look at the scenario, what we were practicing earlier and now what we are practicing earlier, whenever we used to give high-dose chemotherapy, I think in our DM days, everybody was facing this issue. We used to tell the patient that nausea and vomiting is a very common problem in the initial 3-4 days. Nowadays, in our counseling session, we hardly even counsel the patient that nausea and vomiting are the major symptoms because of the drugs which have met the unmet need. So chemotherapy-induced nausea and vomiting was a very big unmet need. We will discuss how it has been tackled with the current generation of drugs and especially Takinzu. And acute nausea and vomiting, I think it has been very well controlled, but delayed nausea is still a problem. When we see the development of delayed chemotherapy-induced nausea and vomiting is a more significant problem than acute. And almost 1/3 of the patients experience this delayed nausea and vomiting. So acute, I think with the present available drugs, it has been very well controlled. If you see the delayed nausea and vomiting, still there is lacuna. So this is still an unmet need in our day-to-day practice. So when we ask the patients what are their concerns with chemotherapy, they won't talk about their PFS, OS, objective response rates. Their concern is mainly the common problems like hair fall, nausea, and vomiting. And in this study, it has been shown that severe nausea and vomiting, they correlated almost next to the death. So this is their dreaded nightmare, uncontrolled nausea and vomiting. And prevention from the start is very important, because if we fail in the first cycle, then subsequent control will become very difficult, because patient will already be having a bad experience, and how much ever we counsel the patient and the combination of antiemetics we use, it's very difficult to control. So as we all know, these are the common neurotransmitters involved, and almost all of these are targetable with the present drugs, and especially the substance P and serotonin, which are commonly involved in delayed nausea and vomiting. These NK inhibitors and 5-3 inhibitors, so they have played a very significant role in our day-to-day practice, and it has made our life easy. So coming to the today's topic, NEPA, which is a fixed dose combination of nativitant and pelnocetron. We have got both IV and oral forms. The oral form is a single oral tablet, and it doesn't require any post-chemo medication. And it has been approved by all the regulatory agencies. And even the current NCCN guidelines also, it is a category 1 recommendation to prescribe this nativitant either in the oral or IV form in moderate and highly immunogenic combination chemotherapy drugs. And it prevents both acute and delayed emesis. This is the advantage of this fixed combination. So nativitant, as we all know, it is only available fixed combination antiemetic, and it is a next generation of NK receptor inhibitor, and it selectively inhibits neurokinin type 1, and also that 5-HT3 component will inhibit the substance P receptors. So it has got a 90% receptor occupancy, and it is long lasting. That is, a half-life goes beyond 3-4 days. So that's why this combination will work both in acute and delayed nausea and vomiting. And the delayed part is where we fail many of the time, because many of our chemotherapy regimens are 3 days and 5 days. And if we don't give a good combination, we face problems, especially after 3 days. So rationale, as we all know, both are synergistic, and inhibiting 5-HT3 along with NK1 is very important. And the advantage of this drug is it is a single oral drug. So it has been approved by all regulatory agencies, and we have got Indian evidence also, which has been published in various forums and various international and national journals. So we'll discuss in the next few slides about 3-4 publications, evidence what we have from our own experience. So these are the common terminologies what we use. Important thing is complete response is no vomiting and no need for rescue medication, and complete control is the same, no vomiting, no need for rescue medication, and there should not be any nausea also. So this was an retrospective study where evidence of novel fixed dose combination, that is NEPA, was used, and it was a real life study from India. So it was published by Vaswani et al. In the World Journal of Clinical Oncology in 2020. It was a single center retrospective study in highly and moderately immunogenic chemo combination. It had got a good sample size of 400 odd patients. The primary outcome of the study was complete response. And if you see the outcome, both acute phase and delayed phase, there was a adequate control. And if you see the overall phase, the complete response was 93%. And the complete response in acute and delayed phase was 98% and 93% respectively. So patients who received highly immunogenic combination, the overall complete response was in 93%, and in patients with moderately immunogenic, the overall response was again similar, 93%. So complete response based on the chemo cycle, we can see that from the start of the cycle, almost all had got more than 90% overall complete response. And complete response was present both in acute and in delayed phase. So the conclusion from the author was NEPA was an effective combination in preventing chemotherapy-induced nausea and vomiting. And it was the first real-life evidence from our setup. And the response was maintained irrespective of, say, the chemo combination what we use, and from the day one of cycle, it was very beneficial. Again, this was the second study where the effectiveness of NEPA in prevention of chemotherapy-induced nausea and vomiting in chemo-naive patients in Indian setting, again published by Vaswani and group. The previous one was a single center study. This was a multi-center study where again 300 odd patients were included, and the treatment was again NEPA from the first cycle of chemotherapy, and DEXA was given based on the clinician preference. And here also, if we see, the response was very good in both highly immunogenic and moderately immunogenic chemo combination. And if you see the complete response, it was almost to the tune of 85 to 90%. So the complete protection was almost like 88%, 81%, and 80% in acute, delayed, and overall phase respectively. And they say recorded the nausea also, and the incidence of no nausea, the overall phase was around 75%. And in highly immunogenic and moderately immunogenic, it was 76% and 79%. So coming to the next publication, which was presented in JCO in 2022 ASCO meeting, where effectiveness of NEPA was again seen or measured in highly immunogenic chemotherapy combination. It was an open label, again multi-center study, but it was a prospective study. And if we see the results again, it is to the tune of what we see in the original phase 3 trial. The complete protection is around 96%, and the complete control is around 85%. Complete control means there will not be any nausea also. Coming to the next publication, effectiveness of again NEPA, multi-center observational Indian study. It was a retrospective study. Again, 300 odd patients were included. Again, both highly immunogenic and moderately immunogenic combinations were analyzed. And if we see the response, again, it matches to what was published in the phase 3 trial. And it was again published in 2023 ASCO meeting. This is one more study where it was published in 2023 ASCO meeting, where 350 odd patients, similar moderate and highly immunogenic combination was used. And if you see the results, again, it matches with the previous experiences. we can see in all phases, acute, delayed phase, and overall phase, the responses are to the tune of above 90 to 95%. And the conclusion was NEPA was found to be effective and well tolerated in prevention of nausea and vomiting in both acute and delayed phase, not only in highly immunogenic but also in moderately immunogenic combination, with more than 90% clinical benefit. So this is the comparison of Indian data versus the published Western data, and we can see that our data also matches with the international standards. So I think from the past experience publications of both from India and from other countries and the original phase 3 trial, I think almost all the trials, the complete response more or less matches. So definitely NAPA is a wonderful drug. Oral is one thing which I think everybody is comfortable, but sometimes, especially in endemic malignancies, where the patient is unable to swallow, the capsule cannot be broken, where we should only give IV. So we have got an IV NEPA combination also, and the advantage is it comes as a prefix, so it does not require any reconstitution. And another advantage is Dexona can be added. So a single preparation can be used on. So it is mainly for convenience, and the results are same. So to conclude, NEPA, which we all know is a fixed dose combination, is highly potent and a long-lasting antiemetic, which is a combination of natividin and pelnosetron. Single dose will help in improving the compliance, and the single dose will control acute and delayed phase of chemotherapy-induced nausea and vomiting. And from our own experience, I think all of us have a very good experience with this combination. And I think with this I will conclude. Thank you.
Thanks, Dr. Ravi, for that wonderful presentation on NEPA. We all use in a routine practice, and it has made our life actually easy, as you rightly said. With that, we'll, in the want of time, we'll quickly move to the next and last session. We'll conclude the session. I welcome Dr. Abhay Kumar for the next session. It's a case-based discussion on HRD testing. We'll rapidly wind up. We go very, very brief in the want of time. Dr. Abhay, over to you.
So thank you, Srinivas, and considering me as a part of this wonderful webinar. So shall I start sharing my slides?
Please, please.
The slides are visible?
Yes, yes.
So it is an interaction between me and Dr. Srinivas. This is regarding integrating HRD testing and maintenance treatment in the first-line ovarian cancer. So we'll begin with the case. So 59-year female with presented with abdominal distension with high CA125 with good performance status, no family history. So diagnosed as a high-grade serous carcinoma on biopsy. So that is a FIGO stage 3 because of involvement of extrapelvic and peritoneal metastasis. So the important question first comes is, should the genomic testing be considered for this patient? So now the genomic testing is standard and it is the norm. And this question is really relevant. All patients, any diagnosed with high-grade serous carcinoma, it is a must. Genomic testing should be done. So the next question to Dr. Srinivas is that, so what should be the followed in this patient with genomic testing?
I think we need to do BRCA, of course, for all the patients, both somatic and germline if possible. And if it is negative, then I'll generally do HRD. What is your approach, Dr. Abhay?
So what I feel is that HRD testing is a good test to consider upfront because HRD includes both BRCA as well as genomic instability score. So even if you don't do BRCA, so HRD can determine BRCA also. So that is somaticam, germline, BRCA, and also along with that genomic instability. So we know that hormone homologous recombinant deficiency occurs because of the mutations in the not only in the BRCA genes and also due to the mutation in the HRR, other HRR pathway genes, and also due to because of the promoter hypermethylation, that is promoter silencing, and also there are some undetermined causes, so which lead to homologous recombinant deficiency. So HRD. So HRD means there is an inability to repair the DNA. So via the high fidelity HRR pathway, so which leads to genomic instability. So there are various methods of detecting HRD and genomic instability. One is the BRCA mutation, which is seen when which is the germline BRCA mutation, which is seen 15%, and tumor BRCA or tumor BRCA mutation, which is a germline non-somatic, is seen in 20%. So HRR mutations are seen in 30%, but when you do screen by genomic instability, that is HRD, is seen in nearly 50%. So every alternate patient of ovarian can have genomic instability. So if you see the 2020 a nice paper about the HRD testing, so they consider that HRD testing by in the ISMO guidelines, they consider HRD testing by genomic instability. So why specifically is because so there are other HRD testing also, just to considering the loss of heterozygosity. So if you see the data about the genomic scar assay, that is genomic instability. Genomic instability is having a good clinical validity and a clinical utility in the first line maintenance as well as in the platinum sensitive refractory disease. Whereas in loss of heterozygosity, so which is done by the foundation, has no good clinical, no evidence as of now in the first line maintenance, but it has got evidence only in the platinum sensitive refractory setting. So which genomic test should be considered to detect a homologous recombinant deficiency in newly diagnosed advanced ovarian cancer patients?
So I think when we asked Dr. Ashna, actually, yeah, they are also doing a modified, customized kind of HRD. But of course, the way the FDA approved one is the Myriad or the Foundation one. I think both are good tests and approved tests for HRD. But since it may not be a very cost effective in our population, because most of our patients cannot afford. If you keep financial things apart, of course, Myriad or Foundation would be a good choice.
Okay, so basically when you look the HRD phenotype, so HRD occurs basically because of there is a HRR gene loss either due to mutations or due to mutation in the HRR genes or in the BRCA testing, and also there are some undetermined causes which leads to homologous recombinant deficiency, so which we call it as a cause, and which leads to effect in the form of genomic instability. So where we measure the HRD genomic instability, which we quantify the genomic aberrations that are characteristic of HRD. So basically, it is a quantity of genomic aberrations. So when you see the HRD testing, usually the HRD testing is done by genomic instability test, which includes the loss of heterozygosity, allelic imbalance, and last state transitions. So if you see this two reports of HRR testing and HRD testing, in HRR panel, they can able to tell only in the any mutation, any loss, and any pathogenic significant alteration in the one of the gene. Whereas in HRD testing, which includes both, that is, they include a genomic score. They go able to tell that whether the genomic instability score is high or not, and also BRCA testing, whether the BRCA mutated, and also it's a combination of both tests. And if you see the exploratory analysis from the Paula 1 study, they found that so HRD positivity, excluding tumor BRCA, is seen in around 19%. But when they assessed with the HRR mutation analysis, so only 6.7% with predefined genes were found to be HRD positive, and only 8% when they expanded the panel, and 3% when they restricted only to 5 genes which are considered more important for the development of high HRD, that is BLM1, BLM, BRIP1, PAL-B2, RAD51, and RAD50D. So when they analyzed the presence of So when they analyzed the presence of HRR mutation, so in the Paula 1 trial, they found that this this HRR mutation has no predictive value of PFS benefit when combined with olaparib bevacizumab versus placebo bevacizumab. So patients who are just HRR mutation, so didn't find any PFS benefit, so compared with the patients with HRD positivity. So, but when they saw that HRD by genomics, HRD by genomic instability score, that is higher score, that is more than 42, even a patients who are having small numbers with non-BRCA HRR mutation population, they found significant benefit when they combined olaparib with bevacizumab, that is median PFS is 28 versus 17 months in the placebo with bevacizumab. So, but when the patients are HRD negative and non-BRCA HRR mutation positive, they didn't find any difference. So both have 16-month PFS benefit. So are single biomarkers measure of HRD testing sufficient to determine genomic instability? Srinivas?
I don't think so. This is not a, see, the HRD, as you said, allelic instability, allelic loss, all those things are taken into consideration. It's not only one marker, I think, because the genomic instability is also equally important.
Yeah. So when you see the HRD, so genomic instability, usually it looks the aberration throughout the genome. So it considers the loss of heterozygosity and telomeric imbalance and last transitions. That is by myriad my choice. But when you consider the foundation one, they only looked at the HRD. So both genomic instability and HRD are approved in the second line. But they usually are distinct and they pick up the different, they have a different methodology and they pick up the different patients. And their correlation is the only 0.87%. So if you see the comparison between all these three tests, so AMOI-DX is basically done in Asian patients. So almost their methodology is same, NGS they consider, but in myriad my choice they include BRCA 1, 2 and genomic instability score, which based upon the three findings which we discussed earlier, with cutoff of the score is more than equal to 42, whereas foundation one they only consider BRCA and a loss of heterozygosity with cutoff of 16. And this AMOI-DX is little bit similar to myriad only, a little bit modified, but they consider cutoff is more than equal to 50. So if you see the this AMOI-DX score, which is similar to a little bit myriad my CDX, so they consider both genomic instability as well as tumor BRCA status, but they here consider the copy number variability they will consider, that is length of copy number, large, medium, small, and type of copy number, that is lots of heterozygosity, or is it a BCNV or allele specific CNV, or site of copy number, so whether it is in the telomere, centromere, others. So based upon these findings, they will give a score. So if you see the correlation between HRD by genomic instability and the loss of heterozygosity, so we can see there are a lot of discordance. That is, if you see in this one study, in the Paula study, so one or two patients with a high LOS score found to be having low HRD score, and this represent potentially false positive case, whereas 24 patients with low score also found to be having high HRD score, so which found to be a false negative. So what are the practical considerations for HRD testing?
The thing is, first of all, what do you mean by that?
Practical consideration means is it going to make any difference in our treatment management?
Yeah, of course. HRD, as you said, 1 in 2 will become HRD positive, and when it is HRD positive, Paula trial showed a significant benefit with PARP inhibitor compared to patients with non-PARP inhibitor, with a very significant PFS and OS benefit. HRD positivity makes a very positive sense in order to tailor the therapy.
Yeah, so HRD positivity is considered when either of them is positive. That is, either the score is more than equal to 42 or at least BRCA mutation is positive, either a tumor or germline BRCA mutation is positive. So we consider HRD negative only when the score is negative and also so BRCA mutation is not seen. So this is the one of the myriad report and AMOIDX report. So I think only the score value is different. Both will reporting the same thing. That is, they will report BRCA mutation positive or not, and also the genomic scar score and genomic instability score. So they also try to assess the other alternative assay and correlation. So the myriad genetics and with the Illumina, Oncostem, Thermo, Fisher and AMOIDX, they found a little bit good correlation between all these tests. And also intra-lab correlation is also very high for this AMOIDX, which is done in India and other Asian part of the country. So it is also important to see in the Polo study that 18% of the patients HRD tests were unknown. So and hence it is also important to know that so whenever you have to send for HRD testing, the important steps to be followed is that should always use FFPE tissue block, and the specimen should contain more than equal to 30% tumor tissue compared to the normal tissue, and at least 100 nanogram of DNA. So any subtype ovarian tissue is acceptable. Usually brain mets and bone metastasis are not a good sites, and also you should discuss with the pathologist and should review the case and select the most optimal sample which contains high tumor burden. The block with highest percentage of tumor should be selected for this test. Usually the tumor size should be more than equal to 25 square millimeter. Omentum and lymph nodes usually are suboptimal samples. So usually when we consider those blocks, we should always use another blocks also. So this patient found to be HRD positive, tumor BRCA negative. So patient received 3 cycles of neoadjuvant chemotherapy, underwent surgery. So 3 cycles of adjuvant chemotherapy. So what next?
So definitely, I'm sorry, I didn't follow you. This patient was HRD positive.
HRD positive and tumor BRCA wild type.
But HRD is positive, right?
Yes.
So of course, then I think we need to give olaparib maintenance, and it is 3C. You said.
Yeah.
And I think I will add bevacizumab with olaparib for this patient.
Yeah. So anyway, ideally, this patient should receive bevacizumab and olaparib. But this patient, they didn't. I don't know the reason they didn't give the bevacizumab. But in such patients, we don't have data for single agent olaparib.
In fact, they should have started the bevacizumab.
Yes. Yes.
And cycle of paclitaxel actually.
Yes, definitely. So is there any role for bevacizumab in frontline management of ovarian cancer? We know that we have already 2 studies are there, GOG 218 and ICON 7. So both studies have proven beyond doubt that there is a PFS benefit with both these regimens. But the benefit is very significant, especially when patients with suboptimal cytoreduction are considered and patients who are stage 4 disease. So should the maintenance treatment be considered for this patient? Definitely, yes. So whenever HRD positivity is there, we have a study for Paula study is there. Patients with HRD positivity, we have olaparib bevacizumab is there, still niraparib is there, and rucaparib is there, even though they are not yet approved. The first line maintenance is why it is more important is that we know that ovarian cancer is an aggressive disease. It will keep on repeating, keep on relapsing. So when the patient, the first relapse, the PFS will be longer, but as the patient goes to second, third, fourth time relapse, the median PFS will keep on reducing. And hence, so when this olaparib has been tried in the first line in the SOLO-1 trial, a long-term PFS benefit was found. So and hence we are prolonging the patient's survival by using PARP inhibitors. That is what the importance of these PARP inhibitors when patient is having HRD positive or BRCA mutation is positive. So what maintenance strategies can be considered for frontline advanced ovarian cancer patients?
Olaparib for 2 years and bevacizumab for 1 year.
So we have already 3 data. So in that 2 are approved. That is a solo trial in patients with BRCA mutated patients. We have olaparib maintenance, and in Paula-1, either BRCA mutated patient or HRD positive patient, irrespective of BRCA mutation is there or not, we have a olaparib plus bevacizumab approval is there. So PRIMA trial, even though it has shown PF, even though it is again has shown PFS benefit in all these HRD positive patients, but it is not yet approved. So what are the supportive evidence for olaparib use in frontline ovarian cancer? We know that these two important trials are there. One is the olaparib single agent maintenance, that is SOLO-1 trial, especially for patients with BRCA mutation, either germline tumor BRCA mutation. And second trial is the POLA trial. We know that it is a combination of chemo bevacizumab followed by olaparib bevacizumab maintenance. So both these two trials have shown PFS benefit and OS benefit. So quickly
wind up the slides.
Yeah, so we'll finish it up. So we know the SOLO-1, the longest PFS benefit, 56 median PFS is 56 months, and the side effects we know the GI side effects and anemia is the important side effects of olaparib. In POLA-1 trial also we can see median PFS of 17 months compared to the 37 months versus 17 months. And if you see analyze the HRD positive patients, whether patients HRD positive, including BRCA mutation positive, excluding BRCA mutation positive, it is for significantly superior PFS has been seen in POLA trial, when with a patient with HRD negative did not derive any benefit. And also there is a patient with HRD positive, we have a PFS and PFS2 benefit, irrespective of whether patient is clinically low risk or high risk. So, and the summary of this PARF inhibitors, all these three studies are there. As of now, only POLA-1 is approved, PRIMA, and all these have shown significant PFS benefit, but they are not yet approved. So PARF inhibitors, usually they have same mechanism of action, but they only differ in the PARP trapping and also some of the pharmacokinetic properties, especially the olaparib are the shortest half-life, so others are having higher half-life. But when in the real world they analyze the which one is the best tolerable PARP inhibitor comparing the clinical event of interest. So olaparib was found to be numerically better with lowest rate of clinical event of interest. So with the significant difference is between niraparib and olaparib. So it indicates that olaparib is better tolerable compared to the other PARP inhibitors. So this is a standard therapy. We know that either neoadjuvant chemotherapy or surgery followed by adjuvant chemotherapy, then maintenance therapy. So we'll conclude with this final slide. So HRD scar score genomic instability of the treatment decision management in the frontline advanced ovarian cancer. So integrate HRD scar score test in frontline advanced ovarian cancer to evaluate both cause and effect. That is, cause includes the mutations and effect includes the genomic instability. So we have a good correlation between the AMI-DX focus and myriad MICHAS, which shows a high concordance. Olaparib is the only PARP inhibitor that has shown more than 3-year PFS benefit in frontline advanced ovarian cancer as a monotherapy in BRCA mutated according to SOLO-1 and in combination with bevacizumab in HRD positive patients in POLA-1. So safety is, we know that it is consistent with across all clinical trials. Major is GI side effects, but when in combined with the bevacizumab, more of hypertension. So thank you very much.
Thanks, Abhay, for that wonderful presentation and moderation. With that, we'll come to the end of today's academic meeting. I would like to thank all the speakers, panelists, participants for successfully contributing for this wonderful academic meeting. And I would like to thank our academic partners, AstraZeneca, Roche, Natco, Zydus, Novartis, Johnson & Johnson, Takeda, and Bayer, Intas, Merck, and Glenmark for their wonderful, generous contribution for this meeting, without which this meeting would not be successful. And last but not the least, I want to thank all my technical support team, Yashika, Geetika, Ektaji, Healthy Blossom, event team for excellent coordination, without which this meeting would not be so smooth and successful. I thank one and all for wonderful participation, and I look forward for such wonderful academic meetings often. If possibly in month of March, we are planning for one more scientific meeting on GI oncology. I thank each and everyone for their wonderful participation. Thanks.
Thank
one and
you.
all. With that, I would conclude.
Thank you, sir. Thank you so much